Now I think I'm able to carry on. It's been a long time coming, but I know change gonna come. Oh, yes it will.
Good morning, everyone. We will get started in just a minute. Please feel free to introduce yourself in the chat box by adding your name and organization. Thank you for joining.
Hi, good morning. My name is Justine Barr, and I'm the chat coordinator for the Bexley, Clinton Township, Canal Winchester, Hilliard, and Westerville chats. I'll now hand it over to my colleague to introduce herself.
Thank you so much, Justine. My name is Olabisi Eddy, and I'm the chat coordinator for Franklin Township, Prairie Township, Southwest, Reynoldsburg, and Whitehall. Before we begin, I'd like to go over some housekeeping. Next slide, please. This webinar is being recorded and will be sent out to all who registered in a few weeks. Please enter your questions or comments in the chat box. We will not be using the raise hand function in this webinar. We will try to respond to as many questions as possible. And if you get disconnected, please use the original link sent in the email to reconnect with us. I'll now hand it back over to Justine.
Thanks, Olabisi. Well, good morning again, and thank you for joining us for today's 2020 Chat Summit. Before we get started, I want to thank Region 5 Public Health Training Center and specifically Donnie Zemmel for making this virtual event possible for us. Along with Franklin County Public Health, this virtual summit is offered in partnership with the Region 5 Public Health Training Center. The Region 5 Public Health Training Center is part of the National Public Health Learning Network. With 9 other training centers across the country, they seek to strengthen the skills of the current and future public health workforce through continuing education and student development. Our theme for this year's summit is Equity in Action, Moving from Theory to Practice. This is our annual event to bring our community and jurisdictional partners together to celebrate the work of the Community Health Action Teams, or as you'll hear us refer to them as the chats. This is also an opportunity to network. The day will also include learning how Franklin County Public Health is carrying out their commitment to address racism and hearing from leaders in various sectors on their work in combating racism and the effects of racism on the health and well-being of communities of color in Franklin County. Next slide, please. By the end of today's summit, we hope that you will leave with an understanding of the purpose of the chats, as well as how to start a chat in your community. We also hope that you'll have a better understanding of why racism is a public health crisis and the effects of racism on the health and well-being of community of color. I'm now happy to introduce Joe Mazzola, our Health Commissioner for Franklin County Public Health, who will give a brief agency overview, and Alex Jones, Assistant Health Commissioner and Director of Prevention and Wellness at Franklin County Public Health, who will be providing a COVID-19 update. Joe, I will now pass it over to you.
Great, thank you, Justine. Thank you, Olabisi. Good morning, everyone. Good to be with all of you. I'd like to say good morning to our staff who are on the call, as well as all of our community partners. Thank you so much for joining us this morning. It's really a privilege to be with all of you, and we want to thank all of you for taking time to be with us here today. As I'm thinking about our remarks here this morning, I'm thinking about our summit from last year and how different this year's summit has had to be because of everything that's happening with COVID-19, but just very humbled that we would have so much participation throughout this year and certainly for our summit here this morning. So my thanks to all of the presenters and everyone else who helped organize our event this morning. Let me start by just a few words about Franklin County Public Health, who we are as an agency. And as mentioned, we're going to turn the call over to Alex Jones for an update about COVID-19. But let me start about little bit about our health jurisdiction. Franklin County Public Health is what's called a general health district. We provide public health services to our 17 townships and 10 villages in Franklin County. And we're also privileged to be able to provide public health services to 14 cities in and around Franklin County as well. In total, that's about 475,000 residents that we serve in our community. It's an incredible, diverse, obviously all of you know Franklin County. It's just an incredible community to be able to serve. Within our health jurisdiction, we also have 13 public school districts, 2 universities, 17 fire and EMS departments, and of course, hundreds of partners like all of you across our public health system, including so many that are involved in our community health action teams. Our vision at Franklin County Public Health is to lead our community in achieving optimal health for all. Our mission at Franklin County Public Health is to improve the health of our communities by preventing disease, promoting healthy living, and protecting against public health threats through education, policies, programs, and I think most importantly, partnerships. And I think that's what today is all about, is that partnership. Our values, as we serve our communities and our organizations, and each of you with integrity, accountability, excellence, respect, and humility. I talked about a little bit about our agency for a second. We are governed by a 5-member board of health. One of our board members is joining us as a panelist this morning, Dr. Arthur James. We have 4 other board members who are actively involved in the strategic direction of our health department. And I want to thank all of our board members for their continued support of Franklin County Public Health. Our staff includes 136 public health professionals. Many of them are on the call here this morning. Registered sanitarians, public health nurses, epidemiologists, administrative staff, public health planners, health educators, communication specialists, and others. We also have a medical director who serves part-time for Franklin County Public Health, Dr. Miller Sullivan, who provides invaluable guidance and expertise from the medical perspective as well. As you probably all are familiar with, we have dozens of programs and services throughout our health department. In our prevention and wellness division, we provide immunizations, we administer the Children with Medical Handicaps program, and we provide reporting for infectious diseases. For environmental health, we, of course, our food safety program, plumbing, community environmental health, and water quality, to name a few of some of our programs and services there. Within our health systems and planning division, many of you know, of course, our health promotion and community engagement staff, but we also provide emergency preparedness activities as well as care coordination and addiction services. And then our administration division, of course, sort of is the backbone to the agency to support all of our programs in the area of communication, finance, and human resources and customer service. Franklin County Public Health is a nationally accredited health department. We achieved accreditation back in 2016. We are actually planning for our reaccreditation in 2021. Accreditation is really an important step in recognition for local health departments across the state of Ohio and across the country. It really tells our community that we have the ability to meet certain public health capabilities. And for us, we will be focused on reaccreditation as we move into 2021, again, to demonstrate that we are committed to quality improvement, as well as the core 10 essential services for public health for our community. I want to invite everyone to certainly go to our website to learn more about Franklin County Public Health. Our agency continues to grow and to respond to the needs of our community. And again, on behalf of our staff and our Board of Health, I'd like to again thank all of you for joining us here this morning. I'd like to now turn the call over to Alex Jones, our Assistant Health Commissioner, to provide an update. Obviously, this has been a very difficult year, a challenging year as it relates to COVID-19. Before I turn the call over to Alex, I want to thank each and every one of you for doing your part and playing your role to help slow the spread of the virus in our community. We've had incredible partnerships throughout Franklin County, our health jurisdiction, and I just want to personally thank all of you for everything that you've done to work with us and to serve our community in this very difficult time. So With that, I'd like to turn the call over to Alex Jones, who has been leading our operations part of our response and has served in a very significant role for our health department as we continue to respond to COVID-19. So Alex, good morning.
Good morning, Jill. Good morning, everyone. Thank you so much for having me here today, and thank you for all you do and spending some time out of your Friday with us here today. So I apologize in advance. I recognize many names in the chat, and I know many of you also join us for our weekly jurisdiction updates that we host every Thursday at 10 o'clock. So today I'm going to spend a few minutes around some of the data that I know you, if you tune into those calls, oftentimes you hear, but also wanted to dig in a little bit deeper to some of the disparities that we are seeing in our COVID-19 data. Certainly, we know that it is not exclusive to COVID-19, that we are seeing these health disparities among other different diseases and indicators, but wanted to concentrate a little bit on COVID today, and then next steps for the chats and working with our community to try to be a more equitable in our response. So next slide, thank you. So this data is a couple days behind. Many of you know we do update our data every day. We aim for in the afternoon around 2 o'clock. So this is the EPI report that we reported on December 9th. So very quickly, I won't go into too much detail here. I want to spend a little bit time on the chart at the end. But as you can see, as of December 9th, we had 21,120 cases of COVID-19. It's hard to believe that this started back in December when we first saw the first case in Wuhan City, China. And now a year later, we are at this place here locally. Important note within this data is that this includes Franklin County Public Health Jurisdiction, as Joe mentioned, the cities, villages, and townships. This does not include the cities of Columbus and Worthington, which are served by our Columbus Public Health partners and colleagues. Our age range is anywhere from less than 1 to 103. Median age is an important indicator for us. As the crisis began, the pandemic, we were seeing an older median age due to this really impacting our elderly population. So at the beginning, it was the sickest of the sick that were being tested and those in congregate care living settings as well. So as the response has gone on, we are seeing more of that community spread and in our younger age populations, which we will dive into here in a minute. Gender breakdown, we are seeing a higher amount in incidence rate in female than male. ICU, hospitalization, and death data. So I'm sure many of you have seen in the news, our hospital systems are very taxed and at capacity, and that continues to remain true. A lot of times they might have some beds open, but there are some staffing concerns. So as Joe mentioned, it is critical for us to play our part, and thank you in advance for what you're doing in your communities to advocate for that and to encourage folks to stay home as much as possible. Death data, over the last week or so, we have seen an increase in our death data, and that is something that we will review in the next table, at the end of the slides deck here around some of the equity that we are seeing, the disparity in that death data. And that's something that is occurring across the state as well. I believe I saw, a 30% increase, so that is definitely a concern. If we scroll down to the next slide, thank you. So this is what we call an EPI curve, and this basically just shows you by date, by reported date, the cases that were reported to our jurisdiction. So you can see from the beginning of the outbreak, when we had that first reported case in March, into December. So we certainly had a peak, and that will be in the next slide here, you'll see. By onset date, so around that 4th of July holiday, we really saw an increase and that we were concerned. And so we were having a lot of conversations trying to encourage our community to stay in. And we know that that was when the stay-at-home orders from the state level subsided as well. So definitely a concern there. But then when we moved into the October, Halloween, Thanksgiving timeframe, we continue to see those spikes in numbers. And so many of you know that the incubation period for COVID-19 is 2 to 14 days. So meaning you could be exposed to somebody and it could take you up to 14 days to develop symptoms. A lot of times we're seeing symptoms develop in that 4 to 5 day time period. However, it's important to note that hospitalizations, which include ICU admissions and ventilator usage, is a lagging indicator. And that just means that you usually well, not typical, but sometimes your course could be, you become sick with COVID-19, and then a week or so later, it might get severe enough where you might need hospitalization, and then it progresses from there in levels of severity. Next slide. So here are our trends for case count. So you can see that we are on an upward trend. This week was a little bit interesting for us, and I'm sure many of you saw in the news that the state of Ohio has decided to align itself with the CDC definition around antigen testing and probable cases. So we did see in our jurisdiction about a 500 case add to our probable case, and happy to explain that in more detail. But basically, this was just, we already had these reported cases. It's just that they were being waited till interview to put them into an assigned category. So we were investigating those cases. They weren't being held up. It was just truly a classification. So it kind of artificially inflated our numbers a bit. But over the last week, with that being taken out, we saw an average about 342 cases reported to us per day. So certainly not where we want to be. Next slide, please. Again, this is just our epi curve by reported date, so not going to spend too much time on this. Next slide. Awesome. Our death data, that as you can see there, that we did have a fairly steady up until maybe about the end of December, and then you see that that bump up. So certainly something of concern for us as we continue through the winter season and thinking about those individuals who might be immunocompromised, vulnerable populations with flu and COVID-19 potentially. Next slide. This is our some interesting data for us that we like to look at regarding hospitalization, race, and ethnicity. So this is going to be broken down a little bit more in the table below. So I'm going to leave this here so you can certainly review this, but we'll get into a little bit more detail in a slide or so. Next slide, please. Our zip code data. So we do look at case rates by zip code. As you can see here, the darker the color, the more cases. And within our jurisdiction, it's really that 43068, so the Near East Side in Reynoldsburg, 43123 Grove City, as well as 43026 Hilliard and 43081 Westerville. So the great news is I believe that all of these areas are actually on this call. So that is amazing for us to be able to utilize you, your teams, and your expertise so that we can make sure that we are getting the messages out, that we are doing everything we can to drive down cases in your communities. Next slide. Again, this just shows the actual percent breakdown of those counties, or I'm sorry, those zip codes and their incidence case count of COVID-19. Next slide. Before we move into some of the disparity data, this has to do with our curve as it relates to age range. So like I mentioned at the beginning of the outbreak, we are really seeing the majority of our cases in our 65 and older population. But as you can see here now, we are seeing the most amount of our cases in that 21 to 30, as well as 31 to 40 years of age range. So certainly an interesting statistic for us to continue to monitor. And I know for our team internally around marketing and strategizing to make sure that we are making messages and having those conversations with those age groups and ranges. And next slide, please. I wanted to spend a few minutes on this slide. This is an analysis that we did from the beginning of our outbreak through the end of November in our jurisdiction. So I want to say thank you to Alex Evans. He is one of our epidemiologists who is assigned to our response, and he is an environmental health epidemiologist who was gracious enough to do this data for us and to lead our data response in COVID-19. So the tables below, you'll see that there's counts, percents, rates, and rate ratios for COVID-19 cases, hospitalizations, and deaths. This includes cases reported through November 30th, They were calculated using the 2018 population estimates for our jurisdiction, which is provided by MORPC. One of the caveats as we dig into the data here is a little bit is that we have approximately a third, 33% of our data, race and ethnicity, that data that is missing. So meaning these are cases that were reported to us without race and ethnicity filled out. Perhaps when we called to interview, the client might have declined to give us their race and ethnicity data. So anything that we can do to encourage that people report this to us, because we anticipate that these numbers are actually an underrepresentation of perhaps the true disparity. So for that top table, if you look here, so 78% of our population in our jurisdiction identify as white, non-Hispanic. 63% of our overall cases are in that category as well. For hospitalizations, 58% are white, and then 72% of deaths are white as well. So it's in that bottom table where you can see some of that disparity as well. So our case rate for our Black non-Hispanic, you'll see there is 1.9% times higher than for white. This is something that we have seen in the news, and this is not something that is unique to Franklin County, but certainly something that is that many of our communities in Ohio are seeing, is that disproportionate impact in our communities of color, specifically our Black non-Hispanic community. Hospitalization rate.
Assistant Commissioner Jones, you have about 3 minutes remaining.
Oh, thank you so much. Hospitalization rate for Black non-Hispanic is 2.8 times higher than for whites. So indicating a severe, more acute case of acute response to COVID-19. And then finally, with mortality and death data, we are seeing that our Black non-Hispanic is 2.1 times higher than for white non-Hispanic. So certainly, as was mentioned at the beginning, we know that COVID-19, that this is not a new phenomenon, that this is something that we see in other health statistics, from infant mortality to chronic disease, heart disease, diabetes, et cetera. So we want to make sure that now with this national spotlight, that COVID-19, that we have other participants and partners who have an interest and who see this disparity. And perhaps this is the momentum that we need to make sure, and being in groups like this, that we are continuing these conversations and making sure that we are moving from theory to practice so that we can eliminate these disparities. So very quickly, before I turn the call back on over to Joe, wanted to say that for us, I know that there's a lot of conversation around vaccine. And so we are having internal conversations with our stakeholders at the public health level, as well as many of you. So I see we would love to engage with our chats and make sure that we are connecting with you and your expertise, as we know that it will be a struggle to vaccinate some of our populations due to some concerns and historical concerns, of course, and some lack of trust. So we will truly need you and your partnership as we embark on this phase 2 of our journey that will happen in 2021. So thank you again so much for the time this morning, and I'll turn it back over to Joe Mazzola. Thank you.
You're on mute, Joe. We can't hear you.
Sorry about that. So I was just saying thank you to Alex for the very detailed overview of COVID-19. I would like to now turn the call back over to Justine. We're going to take a short break and transition, and then go into a more detailed description and update for our chat. So I'll turn the call over to Justine.
Yes, thank you so much, Joe and Alex, for those updates. We are now going to take a 5-minute break, so feel free to get up and get a drink, stretch, and also enjoy this clip from the Black Lives Matter Global Network Foundation.
All right, guys, let's pull sound on camera. There you go. You'd like me to read it? Okay, cool. Dear son, there are so many things I love about you.
I love how strong you are. I love how smart you are.
I love how handsome, intelligent, beautiful, bold, Excuse me. Sorry.
You are getting older.
You are gonna be looked at differently and treated differently.
I hope when you're my age, you won't be fighting the same fights we're currently fighting.
I just want you to come back all in one piece.
You guys matter. But do you know why you matter?
Your life matters because you make the world a better place.
Because you are loved.
You matter more than you know.
You matter.
Love, Dad.
Love, Mom.
Love, Mom and Dad.
What's happening? Brother, what's up? This is a groovy party, man. Yeah, brother, like it's solid. Right on. Hey, man, what's your name? Mother, mother, there's too many of you crying. Brother, 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 there's far too many of you dying. You know we've got to find a way to bring some loving here today. Yeah. Father, Father, we don't need to escalate. You see, war is not the answer, for only love can conquer hate. You know we've got to find a way to bring some loving here today. Oh, picket lines and picket signs. Don't punish me with brutality. Talk to me so you can see. Oh, what's going on? What's going on? Yeah, what's going on? Oh, what's going on? Right on. Hey man, what's your name? Right on. Right on. Mother, mother, everybody thinks we're at home. Oh, but who are they to judge us? Simply cause our hair is long. Oh, you know we've got to find a way. Bring some understanding here today. Oh, oh, oh. Picket lines and picket signs. Don't punish me with brutality. Come on, talk to me so you can see what's going on. Yeah, what's going on? Tell me what's going on. I'll tell you what's going on. Right on.
Welcome back. As we stated earlier, today's theme is equity in action, and we'd like to begin by asking you, how do you define equity? We'll give you about a minute. Please enter your responses in the chat box. Fairness. I like that one. Equal access. Yes. Equal treatment. all people having the opportunity for optimal health. Yeah, those are all great responses. Yes. Everybody getting what they need. Inclusion. Absolutely. Equal opportunity. Yes, those are all great definitions of equity. Next slide, please. So Franklin County Public Health defines equity as the absence of differences in health that are caused by social and economic factors. So achieving health equity means that all people have the opportunity to achieve their full health potential with no one at a disadvantage because of social or economic circumstance. So Franklin County Public Health is committed to addressing the differences in social and economic circumstance and works with partner agencies across Central Ohio, many of which are represented here at the summit. So the chats are another way Franklin County Public Health is acting on that commitment at the community level. I'll now hand it over to Justine to talk more about what a chat is and how to start one in your community.
Great, thanks so much, OLBC, and thank you all for participating in that little activity. So by now you've heard us mention the community health action teams, or the chats as we call them, a few times, and some of you are probably wondering what exactly a chat is. So chats are partnerships between Franklin County Public Health and community members to work together to build healthier communities. We currently have 10 teams in different jurisdictions, and we're looking to expand to serve more jurisdictions. Each chat is distinct in its organization and focus, but all the teams share two common characteristics. They work to improve the health and well-being of their communities and their community-led effort. It's those who live and work in the community who truly know and understand how health issues are presenting and what methods are best used to address those issues. So to talk a little bit about how the chats are structured, each chat has a co-chair to help move the work forward and keep the team accountable. The co-chair is somebody who works or lives in a specific community, and sometimes both. For example, the Westerville Community Health Action Team's co-chair is Dr. Braun. Dr. Braun is a resident of Westerville and a professor at Otterbein University. And now another value of having the co-chair position is that the individual ensures that the team's decisions and work remain community-led. The work of the teams are guided by data presented by Franklin County Public Health and where the chats see a need in their community and the team's capacity to address those needs. Franklin County Public Health collaborates with the community members in the chats to leverage resources and address needs of the communities. Next slide, please. So here's a list of our current chats. We have a chat in Westerville, Whitehall, Prairie Township, Hilliard, Bexley, Clinton Township, Franklin Township, Southwest, Canal Winchester, and Reynoldsburg. So now you might be wondering who are on these teams. We have a variety of partners who are represented throughout the chats, depending on the makeup of the community and the focus of the team. So sometimes we might see partners filter in and out of a team depending on the current focus or project, but for the most part, each of the teams have a core group of about 4 to 8 individuals. And to name a few of those, we of course always have community residents, social workers, police officers, trustee and council members, community health workers, mental health advocates, and nonprofit organizations. Next slide, please. Now I'm going to talk a little bit about how we start chats. The first step in starting a chat is to gain community and municipal support. We certainly don't want to duplicate already existing efforts in the community, and we want to make sure when we start a team in a community, it's something that individuals are passionate about and want to be a part of. So once we've gained community interest and municipal support, we invite those individuals to attend an initial meeting so we can provide an opportunity for introductions and start the strategic planning process. During the strategic planning process, Franklin County Public Health will take the team through an environmental scan, asking them 4 key questions. We ask the team, what do they see in their community? What data is available to them? What other resources are available in their community? And what other people need to be invited to the table? Next, we'll ask the team to identify the community's strengths and weaknesses in their communities. Many of you know this process. Based off of these activities and tools, we'll work with the team so that they can develop a collective mission and vision. And from there, Franklin County Public Health will present data to the team to help guide them as they select an area of focus, or as we call them, a pathway. And I'm now going to hand it back over to Olabisi to talk more about our chat pathways.
Thanks, Justine. So the chat pathways are a framework created to give structure to the chats and help them identify a focus area. So health equity is the underlying foundation for each project we do. The teams are aware of the health disparities within their communities through the data presented, and they make efforts to reach those communities to connect them with the resources they need. So the pathways correlate with Franklin County Public Health's 4 community health improvement plan priority areas. And those are chronic disease, mental health, behavioral health and addiction, access to overall health care, and maternal and infant health. And we also have a pathway for environmental health, which is an issue that tends to be underrepresented in community health planning and discourse. However, it still has a great impact on the health and wellness of local communities. And with the COVID-19 pandemic, we also added 3 more pathways to address some emergent needs, including emergency preparedness, community safety, and digital wellness. So while most of the past and current chats have addressed projects and initiatives that have fallen into these pathways, they're also free to select a project outside of this framework if they identify a need within their community. So one example is the Bexley chat. They started a senior service program that would allow for residents in their community to age in place easier. So this is a living framework. We're constantly adding more pathways and more focal points within those pathways as we continue to expand our partnerships and gain access to new resources. Next slide, please. So we'll now take a glimpse into the work that chats have done in 2020, and I'll now hand it back over to Justine.
So as you can see here on the screen, next slide, please. Our chats have been very busy. In 2018, the teams collectively hosted 17 events. In 2019, 36 events, and this year, 36 events, or 63 events. As you can see, the pandemic has not slowed down the chats in their mission to improve the health of their communities. Instead, they confronted the challenges of COVID-19 and pulled their resources and creativity together to safely provide resources and programming in their communities. To name some of the events that took place this year, Clinton Township and Prairie Township hosted programming to provide healthy foods at no cost to community members. The Hilliard, Prairie Township, Westerville, and Canal Winchester chats tabled at their local farmers markets to provide COVID-19 resources and mental health resources. The Reynoldsburg chat distributed care kits for individuals in recovery. The Hilliard chat hosted a mental health panel discussion, and the Westerville chat hosted a virtual health fair. In addition to all of this programming, some of our chats have been using the year to understand their community's needs and strategize about how they should best address those needs long-term. Next slide, please. Okay. The Clinton Township and Prairie Township chats host monthly produce distributions and partner with Mid-Ohio Food Collective. These produce markets allow community members to access fresh food at no cost. Our chat members will talk more about their produce markets later in the presentation, but we're going to share some collective produce market stats from the past year. So as you can see on the screen, from 2018 to 2020, the number of markets has increased. Just go back one slide, sorry. Thanks. In 2018, Prairie Township hosted 12 markets, and then in 2019, Clinton Township started hosting markets as well, and collectively they hosted 22 markets. And this year, to respond to the increasing need in food resources due to COVID-19, the chats hosted a total of 29 produce markets, and that does not include the 3 markets that they will host this month in December. Next slide, please. This chart shows the number of households served by Clinton Township and Prairie Township produce markets from 2016 to 2019. And a fun fact here is that Prairie Township has actually been hosting produce markets since 2015, and that was before the food bank started collecting stats on produce markets. So they've been in this a very long time. This year, the teams have served over 3,000 families. Next slide. And to translate that into number of meals, up on the screen here, you can see the number of meals that these produce distributions translate into. And this year, the teams were able to provide over 11,000 meals to their communities. Next slide, please. This year, the Clinton Township Chat added a new program called the Commodity Supplemental Food Program, also known as CSFP. This is a supplemental food program for individuals who meet income guidelines and are over the age of 60 years old. One of our chat members will be sharing more about the impact of this program later in the presentation, but here are a few stats. So to date, the team has hosted 5 distributions, and those are monthly, and we currently have a caseload of 36 seniors. I'm now going to hand it over back over to Olabisi, who will be sharing how our chats are addressing environmental and mental health.
Thanks so much, Justine. One pathway that both Prairie Township and Clinton Township adopted as a new focus area is environmental health. As a way to educate their communities on the importance of minimizing mosquitoes and other potentially harmful pests, they distributed 380 magnets and handouts over the summer and fall months to residents through the produce market outreach and tabling at a farmer's market event. We'd like to give a special thanks to our colleagues in our environmental health division for providing those resources for them. Next slide, please. We have various chats that address mental health and wellness. One of the ways they support this work is through the distribution of medication disposal bags. We would like to highlight our partnership with Adam H. Beginning in 2019, they provided free medication disposal bags for us to distribute at community events. This was a great way for the chats to educate residents on the importance of proper medication disposal and promote substance abuse prevention. In 2019, we handed out 806 bags. In 2020, we have handed out 1,828 bags, and with 2 more planned events before the end of the year, we hope to distribute more. I'll now hand it back over to Justine to talk about another partner in mental health and wellness outreach.
Thank you. Yeah, so another way communities are addressing this pathway is the Clinton Township partners with REACT to host Narcan outreach at their monthly produce markets and at the Amos Shopping Center. Through this partnership, REACT has been able to provide 604 kits to Clinton Township community members. And now I'm going to hand it back over to Olabisi, who will share about how our partners are addressing maternal and child health.
So maternal and child health is a complex issue. And in Franklin County, infant mortality especially is at the forefront of current equity work being done at the policy and community level. Celebrate One has partnered with several chats, including Whitehall, Prairie Township, Reynoldsburg, Southwest, and Canal Winchester, to connect with chat members and partners to distribute resources to pregnant women. This year, they have served over 322 women within our chat areas, connecting with them and providing resources to improve the health and well-being of mom and baby. Next slide, please. Access to care remains a top priority for several chats, including Whitehall and Clinton Township. In partnership with the Ohio Commission on Minority Health, we were able to partner with several organizations to implement a Healthy Heart Challenge to promote healthy heart activities. We hosted 2 events with 36 people registered. We administered 33 blood pressure screenings with the assistance of Heart of Ohio Family Health, handed out 103 resource packs with more information on building healthy heart habits. And we also hosted an on-site cooking demonstration during our June produce market in Clinton Township. Next slide, please. In addition to our projects, another way the chats bring value to the community are through the connections and partnerships that are created. None of this work would have been possible without our chat partners. Thank you for the work you've done with us over the past year, and we hope to continue working with you into 2021 and beyond. Next slide, please. So one member coined the collaborative nature of the chats as the chat chain reaction. So one example of this is in our Reynoldsburg team. The Mount Carmel Street Medicine team and Reynoldsburg Senior Center connected in order to introduce diabetes prevention programming into their community. And it's a program that's still running strong today, even as they've gone virtual. Another example is CareSource. They've developed a supportive partnership with the Buckeye Ranch and the city of Whitehall by meeting during the Whitehall chat group. So they've been able to provide assistance and resource information to many organizations going beyond the chat meetings. Next slide, please. I'll now turn it over to 3 of our chat members who will share more highlights on their projects in 2020. Please welcome Elena Sword from Clinton Township, Tanya Lewis from Hilliard, and Nancy Day Acauer from Prairie Township. Elena, I'll hand the floor over to you.
Thanks, Olabisi. Well, hello from Clinton Township. Our free produce market started off this year as a monthly event. Early in 2020, as we all know, when COVID hit, we've seen a surge of new households needing to be served. So we switched our monthly to twice monthly. For some comparison of stats that you've seen earlier in a slide, our 2019 free produce market and households served was 977. In 2020 to date, we have served 2,596 households. Increasing to twice monthly has helped us distribute more effectively and efficiently, not only free fresh produce, but many other essential resources to our community members. Some of those resources are our CSFP boxes, as Justine mentioned earlier. It's also known as the Senior Box Program. We currently have 36 seniors with incomes of less than 130% of the federal poverty guideline signed up. These boxes help vulnerable seniors from having to choose between food and other basic needs. They're either picked up by the recipient or delivered directly to the participant's home, an important feature for our seniors with limited mobility. This program is still in its infancy at Clinton Township and is expected to grow well over 100 boxes when we can safely resume door-to-door screening. Clinton Township's current 36 households are based on word-of-mouth signups and screening during our free produce market check-ins. Clinton Township has also started referring identified persons in need of social services such as mental health, housing, meals, and medical services to our wonderful Franklin County Public Health community health workers. We thank them for this important resource. It is going very well. We've also partnered with the Columbus Division of Fire REACT team to educate and distribute free naloxone kits while waiting in line at our free produce markets and at pop-up naloxone distributions within our township. That includes the Amos Shopping Center pop-ups. The numbers to date are 481 kits distributed at our markets and another 123 at pop-ups. We've also partnered with some local grassroots nonprofit entities, such as the Food Soldier and Rescuing Leftover Cuisine in Columbus, Ohio. Both of these entities have like-minded goals in reducing food waste and eliminating the hunger crisis in Central Ohio. They are both phenomenal with helping us redistribute any leftovers from our produce market and getting the word out. With that being said, I thank you all for being here today and everything everybody's done to come together to make this happen. I'm now going to turn it over to Tanya Lewis with the Hilliard Chat.
Thank you. Good morning. I'm representing the Hilliard Chat. We've been meeting since 2015 and have gone through some transitions within that time. Initially, the Hilliard Chat was mostly comprised of mental health professionals and service providers. Within the last 2 years, we have transitioned to moved more to local community members and developed key connections to such groups as Ohio Health, CareSource, the Buckeye Health Plan, Kiwanis, Neighborhood Bridges, and Village Yoga. Our area of focus is to destigmatize mental health by educating and raising awareness around social health. inviting and engaging new and existing community resources to prevent isolation and stress, and preparing to mobilize in the event of a crisis. During 2020, we were able to shift plan activities slightly and still achieve our goals as much as possible during a pandemic. We participated in 3 Hilliard farm markets, one each for the months of June, July, and August. They were held Tuesday late afternoon to early evening. At the markets, we supplied resources and materials from a variety of our agency members, as well as FCPH. We also provide virtual yoga for you once a month from June through December by Village Yoga. We started with yoga for anxiety and have included breath practices to ease the strain of everyday life. These sessions are suitable for every level of yoga expertise. Kelly even adapts the sessions to those who are chair-bound. These sessions can be viewed on demand from the Village Yoga Facebook page at Village Yoga Yogis. You can join us this coming Monday, December 17th at 7 p.m. for our last session of the year. Finally, we adjusted our health fair and instead planned and hosted a mental wellness virtual panel discussion on October 16th from 10 to noon. We had an adult and a youth panel with a concert pianist bridging the two. We had just over 50 participants, and the panelists include representation from NAMI of Franklin County, Mental Health America of Ohio, Southeast, Franklin County Suicide Prevention Coalition, Ohio Health, a registered nurse, Ohio Sexual Violence Services, Ohio Marriage and Family Therapy, Bravo, and a mental health advocate. We started with an excellent keynote address from Adam H. Our objectives of the conference were to learn how mental health is part of overall health, identify ways that you can continue to care for yourself and others, to empower people to ask for help, and to learn about the mental health resources within our community. Our hope is to continue to build this education experience in 2021. The Hilliard Chat works to continue the education on mental wellness for all, especially the marginalized. Now I'm going to turn it over to Nancy Day Ocker from Prairie Township.
Thank you for sharing that great work for our neighbors up north. I'm actually one of the founding members of the very first chat in Prairie Township. We started in the winter of 2014. And initially it was a group comprised of representatives from Doctors Hospital, part of Ohio Health Systems, our local business association, Southwestern City Schools, Prairie Township Fire Department, Franklin County Sheriff's Office, and Southwestern Libraries. And we spent some time figuring out what it is that we should be working on, and food insecurity was the issue we decided to address, because in Prairie Township, which includes 2 zip codes, 43228 and 43119, and intermingled in there is the far west side of Columbus, we did not have any public food pantry at all. And the nearest pantries, you had to go to another town, code restrictions. There were no produce distributions in our community. So it was very difficult for people who suffered food insecurity to get the fresh produce that they needed. So we embarked on what we thought was going to initially be an easy undertaking, but it took us quite a while to get this up and running. We had to have a 501c3 partner who would sponsor it, and Doctors Hospital stepped up for that. And it took us a few trials and errors to find out what would be the best location, but ultimately our local fire department there in Prairie Township stepped up, and they opened up their Ina Avenue facility. And so they would pull the trucks out, and we had the bays, and we set up our produce distribution like you would be going to the actual produce market. People got to go through the line and pick out the food that they wanted. And we were able to do that up until the COVID-19 pandemic. It's been a wonderful opportunity, though, for 5 years, be building relationships with people in the community, seeing so many people volunteering from our local schools, from Sheriff's Office volunteers. We had had this wonderful partnership with people, and then the pandemic hit, and we lost about 75% of our volunteers because they were older adults. And so suddenly we had a loss of volunteers, and we could no longer work inside of the firehouse because they were understandably concerned about the virus getting inside their building. So we had to move outside. And of course, it had to be freezing cold and windy our first time out in the outdoors. It was 28 degrees. And we managed to pull together, find some extra volunteers to help us out. We caused a traffic jam, so the sheriff's office almost closed this down because we were blocking intersections. But we had people lined up for blocks. And for the first time ever, we ran out of food and had to turn people away. It was a horrible experience to have to tell, really, it was like 2 blocks long of people pulled up, I'm sorry, we're out of food. The following month, we learned from our mistakes. We've learned to be very adaptable. And although it was still freezing cold, although it got up to in the low 30s, our second month of the pandemic doing this, we figured out how to do our traffic flow so we no longer caused traffic problems, but we still had blocks and blocks and blocks of people who needed food. And it was just heartbreaking because so many of these people had never had to ask for help before. It was hard for a lot of people. And they had no, they just didn't know what to do. They would pull up and you have to explain the information that we needed. And there was that awkwardness for some people, afraid that we were going to ask them real personal information. Of course, it's very basic information. So we adapted, we were nimble, and we were able to start a system that ended up being very efficient. We've been able to move people through. It took us 2 months to get it figured out, but now we move people through and we're actually done within the first hour now. We no longer have to go to 11 o'clock because people show up and we get them through the line. And so it's been great to see the efficiency that we've acquired. And although it was challenging to get volunteers, we have expanded our relationships. We've also learned just how much work we can do with a small group, because 2 months ago, only 3 of us showed up initially, and we had to make some phone calls, and we got another 3 people, and 6 of us did the work that normally 15 people do. And we were able to get that
Pardon
done.
the interruption, Pastor Nancy. You have about 2 minutes left.
Okay, thank you. We were able to get it done. And so, although we all agreed we never ever wanted to have to do a produce distribution with only 6 volunteers, we at least know that we can. And then we expanded our relationships. I contacted a friend of mine who works at the Refuge, a wonderful recovery program, and have made arrangements for some of the men who are in the stage of the recovery where they're fully recovered and they're re-entering regular life, for them to send volunteers. And it's a great group of men, and that's a long ongoing partnership there. So it's wonderful that we can now help all these men who are in recovery give back to their community. So for those of you who are considering chats, I just wanted to offer this story to show that, sometimes it takes you a while to get up and running, and sometimes you make mistakes along the way, and sometimes it takes a while to figure things out, but it does get worked out when you're committed, and you can be of great service to your community. So if you're thinking about getting a chat, don't find it intimidating. When you heard these stories, it sounds like, wow, these groups really got it all together. But we've all gone through transitions and challenges of figuring things out. So everyone out there, if you're thinking about it, don't feel that unless you can do it perfect, you shouldn't do it at all. go ahead and go for it. And I think I can speak for all of us in the chats and say, we're happy to tell you about our experiences and, offer some mentoring on that so that you too can be engaged in your community and provide a service that's greatly needed, whatever that service happens to be for your community. So thanks everybody for coming, and I will pass it.
Thank you so much, Nancy. And thank you as well to Elena and Tanya. We will now hand the floor over to Kirsten Oliver, epidemiologist with Franklin County Public Health, to talk about the chat community profiles. Kirsten, I'll hand it over to you.
Okay, thank you, Olabisi, and good morning, everyone. Like Olabisi mentioned, my name is Kirsten Oliver, and I'm an epidemiologist here at Franklin County Public Health. And I'm just going to give a quick overview of our chat community profiles, and that'll serve as a data profile for each individual local community, but we'll get into that a little bit later in the review. So I just wanted to give a little background on how we came to create these. Next slide. So back in 2017, Franklin County Public Health performed our community health assessment, which is a completed profile that contains a collection of information that we use to show the county just how we're doing in terms of health status. And that data that's used in there, we use to identify health needs in our community. So we used a mixed method approach, which included numerical data such as infant mortality rates, death rates, and things like that. But we also gathered data from the local community straight from them so we can determine any other health issues that we may not be aware of through that numerical data. And we use that information for community decision-making and prioritization of health problems, as well as implementation of plans to control or to increase those levels of righteousness in that community. Next slide. And throughout the community health assessment, we did have a focus on health equity. And as you can see with the diagram above, we have our social determinants of health model. And we use that to show that there are other factors in someone's health profile that may not necessarily be clinical that could be affecting one's health status. So we have special consideration for that, as well as overall health equity, that no one should be living in a detrimental state of health, no matter their social connection, but we also focus on race, ethnicity, gender, and sexual orientation with those. Next slide. And as I mentioned, as I mentioned with the, I'm sorry, Donnie, can you go back one more? Yeah, there we go. And as I mentioned with the community health assessment, for those prioritized areas of health, we do make our community health improvement plan. And with that, that gave us our list of 4 areas that we wanted to concentrate on with our efforts of improving the community. And as you can see in that list, it includes, chronic disease, mental health, behavior, and addiction, access to overall healthcare, and maternal and child health. And as Olabisi mentioned earlier, the chat the chat pathways that each chat uses to address concerns in the area also align to this community health improvement plan. And this community health improvement plan was created through a collective impact with HealthWorks Franklin County, which is a collective group of community organizations from different backgrounds, such as clinical, social, education, and transportation organizations that all came together to give that equal overview of their concerns in the community. Next slide. And so that leads us to the community health profiles. And overall, the purpose of that is to give awareness of a community's health status, because as I mentioned with the community health assessment, that gives the county overview, but it doesn't necessarily drill down to the local level. So what we're hoping to do with the chat profiles is to give each of the 10 chats their own data profile so they can see what's going on in their local community. And that way we can get it in alignment with any of the pathways that any of these chats want to focus on. And as you can see on the list, some of that data will include local data with breakdown by race and ethnicity, so we can address those health equity disparities that we may see. And it will also include physical environment and environmental health, maternal and infant health, and infectious disease outbreak information. Next slide. And just to give a little overview of how that process would work in terms of data collection, it is an intensive process that we have to go through just to make sure we're getting reputable data and accurate data for each individual health jurisdiction. So just to quickly go through that list, we start with determining the important indicators as they align with our CHIP, as well as the CHAT pathways. And that kind of goes into us researching those data sources. So finding those reputable sources that we can trust, that isn't sort of a word of mouth thing, but is backed up by scientific evidence. And then that goes into us creating that data dictionary so we can accurately keep track of all the data indicators that we have. And we can also update them as newer data is available. And once we're done with that, we add our citations just to make sure that we're giving credit where credit is due with the collection of this information. So once any of that data is added in, like I said, if we see any updates, we can update the source as well as the numerical data itself. Next slide. And some outcomes that we're hoping to have with these community profiles is that we provide options for newer pathways. So with some of the data we provide, there may be some disparities that come out in this data that the local community wasn't aware of. So as Olabisi mentioned, there are some pathways that don't necessarily stick with the list that was included in that display she showed. So we can offer an avenue for newer pathways, and we have that data to back it up to show how that local disparity needs to be addressed. And we can also, in the next data point, we can promote collaboration with other local communities. So as Olabisi mentioned, there is some collaborative efforts that are done across chats. So if there's one chat that's working on something and another chat realizes, oh, we have that similar issue, then they can initiate that collaborative impact for them to both focus on that in their individual areas. And also something new that we're looking into, we're hoping that chat agencies with this data can use it for grant and funding opportunities, because we know there is funding out there. As long as you have the data to support it, it can be obtained. So we're hoping with some of this local data, it can provide the chats with opportunities to apply for funding and receive that award for them to focus on disparities in their areas. Next slide. And with that, that's the end of my presentation. And I'm gonna turn it back over to Olabisi and Justine. Thank you.
Great, thank you so much, Kirsten. So now we would like to take the next couple minutes and answer any questions that participants have for us so far throughout this portion of the presentation. If you have any questions about the chats, chat profiles, any questions about the specific projects of the chats, we'd love to answer those. Please just submit your question through the chat box. So it looks like we have a question for Kirsten. Attendee asked, are the community profiles already done?
Currently, unfortunately, no, because of the pandemic that we're all suffering from. Some of us have had to sort of realign our work with assisting our health department with obtaining data and things like that with COVID. So some of that data you saw Alex present earlier, we've been kind of prioritized with that. But we do have some drafts on the way, and we're hoping to release them in early 2021.
Great, that addressed the next question as well when somebody asked if when the profiles will be available. Okay. But we certainly understand that the current situation with COVID-19 presents some barriers. All right, well, if there aren't any questions, Kirsten Oliver's contact information is up on the screen, so you can reach out to her for specific questions about the profiles. OBC and my contact information was provided through the Summit registration link, but we'll provide that at the end too. So if you have questions about the chats or the work that they're doing, or you're interested in starting a chat in your community, we'll share that later as well. And I think we will take another short break. So please get up and stretch and enjoy this slideshow of the chats over the past couple years.
Sometimes in our lives, we all have pain, we all have sorrow. But if we are wise, we know that there's always tomorrow. Lean on me when you're not strong, and I'll be your friend. I'll help you carry on, for it won't be long till I'm gonna need somebody to lean on. Please swallow your pride if I have things you need to borrow, for no one can fill those of your needs that you won't let show. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. Lean on me when you're not strong, and I'll be your friend. I'll help you carry on, for it won't be long till I'm gonna need somebody to lean on. You just call on me, brother, when you need a hand. We all need somebody to lean on. I just might have a problem that you'll understand. We all need somebody to lean on. If there is a load you have to bear that you can't carry, I'm right up the road. I'll share your load if you just call me. Call me if you need a friend. Call me. If you need a friend. Call me. If you ever need a friend. Call me. 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 If you need a friend. Call me. 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 Call me.
Welcome back, everyone. We will now introduce Teresa Seagraves with Franklin County Public Health, Assistant Commissioner, And we would also like to welcome back Joe Mazzola to give a brief presentation on the declaration of racism as a public health crisis. Teresa, I'll hand it over to you.
Actually, I think Joe's going to kick us off. So, Joe.
Yeah, thank you, Teresa. Thank you, Olabisi. Good to be back. I want to just maybe pause for just a second and just reflect on those pictures that were just shared and the presentations that were just made. It's really remarkable to see the impact that our chats are having in our community. Obviously, this year has been a unique and challenging year for obvious reasons, but to hear again the descriptions of some of the chats and the adjustments and the changes that they've made over this course of the year have just been really inspiring, particularly given the need that our community has right now. So when you think about the impact that COVID has had and the disparities that we continue to see is in terms of food access and economic opportunity and so forth, this year more than ever, we need those programs and services. And so I just, again, want to extend my thanks to all of the chat members and to our staff who continue to support the chats for those needed services. And thank you, Kirsten, Oliver, for the profiles. Looking forward to having those available as we go into 2021. It's a very, very vital part of what we do here at the Health Department. Next slide, please. So we wanted to take a few minutes and talk about our declaration regarding racism as a public health crisis. But before we get there, maybe just a few thoughts about the journey that Franklin County Public Health has been on as we look at the issue of equity and addressing the issue of equity in our community. What you see in front of you here is a slide about those 10 essential services that I talked about earlier this morning. As I mentioned, we are a nationally accredited health department, and as part of accreditation, it's our duty to demonstrate that we meet these 10 essential services. And in the middle of these essential services, you see in this framework the idea of equity. So for us at Franklin County Public Health, it's very, very important that we align our work to this national model regarding these 10 essential services. And through accreditation, we have done that over the last 5 years. But we needed to take a step forward to really move that work and advance that work for our health department. So if you could go to our next slide, please. So Kirsten covered a little bit of this in her presentation, but I do want to just emphasize this a little bit more. So as we think about that framework that we just looked at, part of that is assessment and planning and incorporating equity into that. And our community health assessment back in 2017 was our first step in doing that. I hope and I would encourage everyone to look at that assessment. It really is a very complete profile for our entire health jurisdiction, our county. And it was our first step in this alignment of our work regarding equity. And so as we look, as that process ended and we looked into the next step for our community health improvement plan, and Kirsten talked about this as well, we really wanted to center around this idea around social determinants of health. We know that we have to get to those underlying health conditions, those underlying conditions that really present barriers for our residents to achieve the optimal health for our residents. So in our CHIP, and you saw it in the presentation, we have this framework that we've been utilizing regarding social determinants of health. Many of you who are part of the HealthWorks Franklin County group helped create that with us. And that really is, again, our framework to align our work in terms of our public health planning with the work of social determinants of health. So our CHIP that was developed in 2018 is centered around that social determinants of health framework. It includes those 4 health priority areas that Kirsten talked about. And again, is our roadmap to improve the health of our community here in Franklin County. With the CHIP completed, our next step in terms of our planning process at the health department is then to adopt a strategic plan. And so in 2019, our Board of Health, along with our staff, created our new strategic plan for the agency based on our community health assessment, based on our community health improvement plan, and then as an agency, how we envision our agency supporting that and supporting the work that we are charged to do on a day-to-day basis. And in those conversations, our Board of Health adopted one goal for our agency, and that is to incorporate equity as the foundation for conducting our daily work. So in other words, we as the health department have now said that everything that we do at Franklin County Public Health will align with the idea of equity. And I think that's really critical. And it has been something that I think has transformed our agency and is transforming our agency, both internally and externally. And I think for us, it gives us that North Star and that one idea to focus on as we conduct our work. Within our strategic plan, we also have 4 objectives to support that goal. Objectives regarding how we engage with respect to social determinants of health, objectives around policy, objectives around how we are utilizing data, and funding as well. And let me just speak for a minute about all 4 of those. I mentioned that social determinants of health framework that was shared earlier. Again, using that framework and then this goal of equity, we are now aligning our work with those other areas, and we're engaging with partners that address those particular areas. One example of that would be the Rise Together plan that the Franklin County Board of Commissioners has led to address poverty in our community. Franklin County Public Health has been an active partner in that plan and will continue to be an active partner within that plan moving forward. Other efforts around transportation, around food access, around education, like Future Ready Columbus's initiative to improve kindergarten readiness in our community. Those are the types of initiatives that we are engaged with now because of this new plan and because of our emphasis around social determinants of health. From a policy perspective, and Teresa's going to talk about our health and equity and our policy, we know that policy is critical to, again, improving the health of our community. So we are looking at both internal and external policy opportunities, again, to achieve our goal of equity. From a data perspective, we're looking to create more real-time and more actionable data for not only for our health department to use, but also for our partners to utilize. I think our profiles are another example of that, and we're looking to build data systems that really will help inform our work and, of course, inform our future public health planning with our partners as well. So that will be a critical objective for us moving forward. And then finally, funding. We all know and recognize that funding is a critical part to how our agencies are able to operate and how our partnerships are able to strengthen and to be and to grow. So we're looking at new and unique funding opportunities, both for the health department as well as looking for more opportunities for our partners from a funding standpoint as well. And so we really want to make sure that from a funding standpoint that we're diversifying our funding and looking for unique funding opportunities and really significant funding opportunities around those priority areas that we are looking to address within our community health improvement plan. One great example that many of you may be familiar with is our overdose data action grant, which the CDC funds for us. It's about a $4 million grant that we were awarded in 2019. And just again, a significant funding opportunity for us to be able to distribute those dollars into the community to address the issue of addiction, the disease of addiction in our community. So that's kind of a backdrop of kind of the journey that we've been on and how all of these initiatives kind of align. If we can go to the next slide, please. Thank you. So that kind of brings us to 2020. And as we, as a health department, continued on this journey, we know that structural racism causes persistent discrimination and disparate outcomes in many areas of life. And we also recognize that if we are really going to achieve equity, we have to be able to address the issue of systemic and structural racism in our community. There have been several conversations that had started both here in Franklin County and across the country that dialogue had started, and we knew that as a health department that we had to be a part of that conversation and really lead that conversation. I do want to recognize Dr. Arthur James, who's going to be joining us here in a few minutes for a special presentation. It's because of his leadership as a board. Our Board of Health wanted to explore this declaration, and we put in a lot of time and effort to research the connections between structural racism and health outcomes, and ultimately passed a resolution in May of 2020 this year declaring racism a public health crisis. We were the first health department in the state of Ohio to do this, actually the first public entity to declare racism a public health crisis. And since that declaration, we have seen many of our local community partners, our local cities, hundreds of businesses, our other county and city agencies across Franklin County also declare racism a public health crisis. And for us, that's extremely humbling because as a community, we know that the first step in this process is actually naming the problem. And we had to be able to step out and do that. And I'm just very, very proud to serve at an agency who was committed and willing to do this work and to really make sure that as a health department, we were taking the steps that were necessary in order to declare racism a public health crisis. Now, naming it is that first step, but what will we do next? And I think that is the question we have been receiving from many of our partners and our community moving forward. So in our declaration, and I would encourage everyone to read the declaration that the Board of Health passed in May, it talks about 14 different action steps that are in the declaration, both for the health department to take both internally and externally. I won't go through all of them this morning, but some of them include hiring our new Associate Director of Equity and Inclusion, Lisa Dent, who will be joining this conversation later this morning, as well as the adoption of a health and equity in all policies policy. And so, there are a lot of steps that we're going to take moving forward, but this was a significant decision by our board, and I hope a step that helps move our community forward as we continue to address these underlying policy systems, procedures that really create those social determinants that are creating those barriers for our residents to achieve their optimal health. So what I'd like to do is turn the call over now to Teresa Seagraves, our Assistant Health Commissioner and the Director of Health Systems and Planning, to talk about this new policy, the Health and Equity in All Policies policy. Teresa was instrumental in creating our resolution declaring racism a public health crisis. I want to thank you, Teresa, for your leadership in that process, along with Dr. James and our board and others. And I'd like to turn the call over to you to talk about this HEI-AP and how our partners can utilize this new policy within their organizations and within their communities.
Thank you, Joe. And good morning, everybody. I'm so happy to have you all here with us today. And before I get started, just a couple things. I do note that there is a question in the chat box for us, and we will get to that in just a minute. I do want to take a pause, not only thank you all for being here, but I really want to thank Justina Olabisi for all the work that they've done in pulling the summit together. They've done this as they are still working within our ICS structure around COVID. And so I can't thank them enough for the great job that they've done. So picking up where Joe left off, just wanted to highlight you on a few things that we've done around our health and equity in all policies. So it was very important, and we were sort of doing this in tandem with the declaration, but it was important for us to have a policy, and our policy was really going to be the template or the guide that we use to kind of outline what was our next steps going to be once we declare racism a public health crisis, but also internally, externally, how are we going to operate? And we felt that health and equity, and I want to just point that out or pause there for a moment, because it's very important to note that we didn't just say this was a health equity policy. It is a health and equity. And it's very important to distinguish that, because calling it a health equity policy would have meant something very different, and it would not have put that focus on equity. So just want to make that distinction and point that out for all of you. So with our policy, what we really did was we provided a rationale in the policy for why we were doing this. We thought that was important for us to share that with our staff, so that all staff looking at the policy will have an understanding of why, going back to the data that Joe mentioned, why this policy is important and critical. In our policy, we also provide definitions. We wanted everyone to understand when we use certain terms, what those terms mean, so that we would all be on the same page. We also clearly, within our policy, we highlighted the roles and responsibilities. And we started with, every level of the organization. So we defined a role for everyone up through our Board of Health. So everybody has a role in this and making this a reality. What I'm going to do here today, just briefly, is highlight both some of the internal as well as external activities that we've either completed or we are in the process of completing in order to address our health and equity in all policies work, as well as our declaration work. So I'm going to start actually with this third bullet, because it's very important. One of the first things that we did was we created an internal health equity committee. That committee is comprised of staff throughout from all levels of our agency, and all divisions within the agency are represented on that committee. The Health Equity Committee, and I want to make sure that I acknowledge this, are really responsible for the policy. We did that as a group. That was one of the first.
Assistant Commissioner Seagraves, there are about 2 minutes remaining.
Okay, thank you. I will speed up. So that was one of the first things that we did. As you can see here, training. We wanted to train all of our staff on having crucial conversations around racism and equity. So our goal was to complete that training for leadership by the end of this year. And we are on track to do that. We have now trained all of our leadership. We have a few people that for various reasons might have missed it, but we are basically on track to have all of our leadership trained. And in 2021, we will focus on the rest of our staff. We will be assessing our policies and procedures through an equity lens. And that's a big part of the work that Lisa will be leading, that Joe mentioned, and you'll hear from Lisa later. We're also looking at funding. We're both looking at funding from the lens of who do we contract with, who do we provide funding to, and is that funding being equally distributed in an equitable way, but also, we're trying to, optimize our funding focus and the projects that grants, opportunities, whatever it is, that we engage in to ensure there's an equity lens. Next slide, please. And then some of the external activities we're involved in, one of the biggest is creating an equity advisory council. We have now made invitations to appoint individuals to this council and we have gotten a good response. The council is very diverse, represents many different groups and organizations. And our first meeting will be on December the 18th as official advisory council. We're also trying to do things like educating the community, especially, the organizations that we engage with. So this chat summit is an example of that. We want to share information around equity and racism with, especially our chats, but with our jurisdictions and other local communities. So we are in the process of having a very, kind of defined way of doing that, and we're starting through our chats. And we're also partnering with other organizations that are like-minded and have adopted a declaration of racism as a public health crisis. We know we can't do this work alone. We know it's critically important that we have a structure around how we do this work in order to really make a meaningful impact. So those are some of the external things that we're doing. You will definitely be hearing more from us, and we will be engaging many of you on this call as we move forward with this work. And with that, I'm gonna turn it back over. Oh, before I go, if there's any questions, please put them in the chat. We will address your questions. If we don't get to verbally now, we will send out a response. The one question that I did see about how high of a priority is equity in our vaccine distribution, I can tell you, and I don't know if Alex is still on the call, that is something that we are in the planning process for now. We're looking at data around disparities. We're taking into account the fact that there are going to be some racial and ethnic groups that may not be inclined to take the virus, and how do we deal with that? This is a topic we're going to bring to our Equity Advisory Council for discussion and feedback. So it is very important, and it is very high up on our priority list. If you have any questions, please feel free to reach out to either Lisa, myself, or Joe. And with that, I'll turn it back over to Joe to introduce our next presenter.
Great. Thank you, Teresa, very much for all of that. Really appreciate it. And again, thank you to you for your leadership in terms of our internal and external engagement regarding equity and our racism as a public health crisis declaration. Really appreciate you being on the call this morning. It's my pleasure now to introduce Dr. Arthur James, one of our 5 Board of Health members, for a special presentation regarding the intersection of racism and public health. Many of you, I'm sure, know Dr. James, and it's really a privilege for us to have him on our Board of Health. Dr. James has spent his career practicing not only medicine, but also practicing public health. And again, very fortunate for Dr. James to be able to join us here this morning. Thank you so much for being here. Let's turn the call over to you, sir, Dr. For your presentation.
Thank you for that introduction, Joe. Like others, I want to thank all of the attendees to this meeting, especially want to give a shout out to the folks at Franklin County Public Health for the wonderful work you've done, not only in terms of this declaration of racism as a public health crisis, but especially during this time of the pandemic for the great work you've done in terms of assisting our community to address this COVID issue. Next slide, please. So this may seem like a strange place to start this presentation, but I start with this definition of public health for 2 reasons. One is that there are people within public health who don't feel that public health should be involved in addressing the issue of racism. And 2, there are organizations like the NAACP and others who have been working on dealing with racism for a long period of time, who have had some reluctance in accepting that those of us in public health have a role to play in this issue. So this definition says that Public health is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. Next slide. The CDC also makes sure that we understand that public health is the science of protecting and improving the health of people in their communities, of all people, not just certain people, and that public health is concerned with protecting the health of entire populations. It could be a very small community to a large community, including even the world. Next slide. Sometimes people confuse the issue of public health with what we do in terms of the provision of health. You may, in terms of your health maintenance, go see your doctor once a year. But we need public health all of the time, every minute of our lives, for all that it covers, as is made clear by this quote from a former Surgeon General, Dr. C. Everett Koop. Next slide. So where I'm concerned, my personal perspective is that when we look at the racial disparities that occur in outcomes in general, not just in health, but across the board, that those disparate outcomes that we measure are the consequence of centuries of policies, practices, and systems that have intentionally provided advantage to some while simultaneously intentionally subjecting others to disadvantage. And that advantage, disadvantage, inequality here is based on racism. Next slide. I use this as an example. This slide shows the Black infant mortality rate in the United States in 2017, and it shows the states that report a Black infant mortality rate to the Centers for Disease Control during this period of time. This doesn't show, for example, the overall infant mortality rate in Ohio. It doesn't show the racial disparity in Ohio, where Black babies in our state die at 3 times the rate of white babies in the first year of life. What it shows is just the Black infant mortality rates for the states in our nation who report this data. The red bar, of course, is the state of Ohio. And what this slide is saying to us is that in 2017, there was only one state in this nation where Black babies died at a higher rate than they die in the state of Ohio. And for those who feel comfortable suggesting that the racial disparity in birth outcomes is a consequence of genetic differences between those of us who are Black and others, I ask you to look at the second blue bar from the left that looks at the state of Massachusetts and their Black infant mortality rate, where Black babies in the state of Massachusetts have a better than 2 times survival opportunity than Black babies born in the state of Ohio. So if in fact it's genetics, we'd have to argue that Black people in the state of Massachusetts are significantly different from Black people here in the state of Ohio. And I think we know that that's not the case. Next, and the other point I want to make on this slide is that for those of us in Franklin County delivers more babies overall and more Black babies than any other county in the state of Ohio. So we significantly contribute to this terrible data relative to Black infant mortality. Next slide. So I want to spend a few slides talking about the definition of racism. And for this, I use Dr. Camara Jones's definition that defines racism as a system, not just a one-on-one issue of concern, but a system of structuring opportunity and assigning value based on race that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and thereby saps the strength of the whole society through the waste of human resources. Next slide. Dr. Jones defines 3 levels of racism: institutionalized, personally mediated, and internalized. Next slide. For institutionalized racism, she defines it as the differential access of goods, services, and opportunities of society by race. Next. And for that, she provides examples. Next. And this helps to explain the association between social class and race. Next slide. Where personally mediated racism is concerned, she defines this as the differential assumptions about the abilities, motives, and intents of others by race that can result in differential actions based on those assumptions. Next. That can result in prejudice and discrimination, and she provides examples. Next slide. Where internalized racism is concerned, this is the acceptance of, by the stigmatized races of negative messages about our own abilities or intrinsic worth. In other words, this is about, in the case of African Americans, us believing the lies that racism has told about us as a group. Next slide. And again, she provides examples. Next slide. Health Policy Institute of Ohio pulls out of Dr. Jones's definition this notion of structural racism, which they defined as racial bias amongst institutions and across society. Next. These 4 levels, next slide, please. These 4 levels of racism, which are on the outside of this slide, show that racism in its various forms influences every aspect of our lives. Next slide. I'm going to go through a few historical periods of time to make the point here that this whole recognition of racism and how it influences our lives is not new, that we can go back as far as 1899 and the work of W.E.B. Du Bois in the book, The Philadelphia Negro, where he acknowledges that the Negro's problem is not rooted in their heredity or their genetics, but rather their environment and social conditions. In other words, how this country manages Negroes then as a group. Next slide. In 1966, Dr. Martin Luther King Jr. reminded us that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Next slide. In 1968, as a consequence of all of the race riots that were taking place in the United States, even after the passage of the Civil Rights Act, President Johnson formed this commission, the National Advisory Commission on Civil Disorders, to look at what was going on in our country and why, after passage of the Civil Rights Act, we were having all these riots. In 1968, that commission is famous for this quote that our nation is moving toward 2 societies, one black, one white, separate and unequal. Every decade since this initial study was done in 1968, the Eisenhower Foundation has looked at disparities in our country between blacks and whites, and every decade since then have documented, in fact, that the disparities have gotten worse. Next slide. This looks at a 1985 study by the Secretary's Task Force on Black and Minority Health that's commonly known as the Heckler Report, where she documents that ethnic minority groups in this country don't benefit as much from medical technology, and of course, in part as a consequence, experience significant disparities on the basis of race. Next slide. And of course, in 2002, there was this study done by the Institute of Medicine entitled Unequal Treatment that said that even when insurance and income were comparable between minority groups and whites, that outcomes for minority groups were concerned was compromised, but the compromise was in large part because of a compromise in care and the quality of those lives lived by marginalized groups. Next slide. One of the members of that group that did that study was Dr. David Williams, who said, "The stability of racial differences in health is striking. This is not an act of God, neither does it simply reflect racial differences in individual behavior or biology. Instead, considerable evidence suggests that these striking striking racial differences in health and their persistence over time reflect in large part policies and practices that are linked to the historical legacy of racism. And that legacy has created living conditions that are pathogenic for minority populations. Next slide. Then in 2003, the World Health Organization came out with this study that they called the Solid Facts, that document that our living conditions contribute significantly to our health situation, which they defined as the social determinants of health. Next slide. They further went on to say to us that if we were willing to pay attention to the social determinants of health and this disparate outcomes that we were experiencing, if we were willing worldwide to pay attention to that and address it, that we could in fact eliminate disparities in health outcomes within a generation. Next slide. So one of the questions that we often ask today is, what ought our emphasis be? And I think that the national literature would suggest to us that what's winning the argument is that our aspiration needs to be to achieve health equity. Next slide. And you can activate this. But I am of the opinion that we have no chance in achieving health equity without first achieving equity. That equity should be our primary goal, that it should be our North Star. Next slide. Nancy Krieger reminds us that social inequality kills, that it deprives individuals and communities of a healthy start in life, increases their burdens of disability and disease, and brings early death, that things like poverty and discrimination, inadequate medical care, and violation of human rights all act as powerful social determinants of who lives, who dies, at what age, and with what degree of suffering. Next slide. Healthy People 2020. The national aspiration for our health goals that we currently still operate under said to us that the conditions in which we live explain in part why some Americans are healthier than others, and says to us that we have to be intentional about creating social and physical environments that promote good health for all people. Next slide. And so we come to this place where not only here in Franklin County, throughout the state of Ohio, but across this nation, many locations have been involved in declaring racism as a public health crisis. Next slide. Some of the tenets of that include some of the things that Commissioner Mazzolo has already mentioned to us, that it's important to name racism, that we have to find the resources necessary to mitigate the consequences of racism. It's important to have health and equity in all policy that Commissioner Seagraves mentioned. I would even suggest where number 3 is concerned that we probably need to reconsider naming that to equity and health in all policies, that inclusion is important, and that's one of the primary reasons that these chats are so significant, because we need to hear from folks on the ground to engage and involve them in these essential conversations. And of course, healing the harms that have been created by racism is also very important to us. Next slide. So in general, what I'm saying is that in our country, we have created what I refer to as structural determinants, those policies, practices, and systems that in fact determine the living conditions that we experience, and those that we refer to as social determinants. And those living conditions have consequences. Those consequences in many cases, for in particular communities of color, result in marginalization and compromised outcomes. Next slide. So I want to spend a little bit of time going through a little bit more history in terms of examples. And some may say, well, why are you spending time doing this? The analogy that I would use is that I think it helps people to understand how to untie a knot if you first understand how the knot got tied in the first place. So acknowledging and appreciating the history that got us here is important if we're going to be involved in the effort to resolve racism. Next slide. And I'm going to start with mass incarceration that occurred in this country. Next slide. It occurred as a consequence of our war on drugs. It was a contrived war. Understand that it was something that was made up by the Nixon administration in order to fight Blacks and hippies during his campaign and subsequent administration. Next slide. Ronald Reagan doubled down on that war, creating mandatory sentences, sometimes for minor infractions, but because that war on drugs preferentially was aimed at ethnic minority groups, particularly Blacks, it had a devastating effect on the Black community. Next slide. So compared to whites, Hispanics experienced 2 times an increased risk of arrest from drug use, and Blacks 4 times an increased risk of arrest. Next slide. And according to Michelle Alexander, it is the war on drugs that is the engine behind mass incarceration. Next slide. And it results in this disparate incidence of incarceration that you see on this slide, where the Black incarceration rate is outlined on the top, the white incarceration rate on the bottom. Next slide. So that the overall incidence of incarceration is outlined here. I try to point out to folks that if you look at the incarceration rate represented on the left side of this slide, understand that the population of the United States didn't change significantly between the left side of this slide and the right side of this slide. What changed were our policies, practices, and systems that from a racial perspective targeted one group over another group, resulting in deleterious consequences to that group that these policies were aimed at punishing. Next slide. This has resulted in today an incarceration rate for Black and brown individuals, men and women, significantly higher than for whites. And think about how devastating those arrest records are for, or arrest history is for dismantling Black and brown communities in this country. Next slide. As a consequence of this war on drugs and mass incarceration, the United States now has the highest incarceration rate of any nation in the world. And when we connect this to history, understand the following, that at the end of slavery, the United States was the largest slaveholding country in the entire world. Fast forward 100 years, and we've arrested enough of the descendants of those slaves that we now have the highest incarceration rate of any country in the world. Next slide. So that even though the United States only represents 4% of the world's population, we imprison 25% of the prison population. Next slide. I think it's also interesting that when we come now to this current opioid epidemic, where the primary users are white, that we in fact have elected to change our approach. That even though opioids are considerably more dangerous, risk of death considerably higher than for crack cocaine use, we have elected to medicalize our approach today to opioids as opposed to what we did to Black folks in terms of criminalizing our approach. It is a contemporary example of racism in our country, where we have treated one group in a better manner than we have another group. I'm not arguing against the medicalized approach to opioid use. I think it's the appropriate way to go, but I also think that that should have been the approach for communities of color where crack cocaine was concerned. Next slide. So in summary, for our history, this country subjected African Americans to 246 years of slavery. followed by another 99 years of Jim Crow. It's only been 56 years since passage of the Civil Rights Act. And to put that in context, next slide. Slavery and Jim Crow together to this day account for 86% of the African American experience. 86% of the time where we have provided preferential advantage to those of us who are white while simultaneously subjecting those of us who are blacks to substantial disadvantage. And whenever we compare blacks and whites today, we never talk about this history. We never acknowledge the significant advantage we've given to one group over another group. We make those comparisons today as if the playing field has always been level, as if it's always been fair. And of course, that's not the case. Next slide. Last year represented the 400-year anniversary of slavery. And I'd like to suggest to this group that 400 years of how we've treated Black folks in this country is enough, that we have to figure out a way to change things, to turn this page, and declaring racism a public health crisis is one of the steps, in my opinion, that's necessary for us to take. Next slide. The Declaration of this country says to us that we hold these truths to be self-evident, that all men and women are created equal, that they are endowed by their creator with certain inalienable rights, that amongst these are life, liberty, and the pursuit of happiness. Next slide. But
Dr. James, we have about 5 minutes remaining.
Incidents like Hurricane Katrina, the increased incidents of killing of unarmed Black people, our country's high incarceration rate of people of color, the racially disparate outcomes for cases and deaths from COVID, and yes, the disparity, persistent disparity in infant mortality and maternal mortality all spell out to us that not all of us benefit from this declaration equally. Next slide. My point here is that forget this stuff that we've been indoctrinated with that suggests to us that the disparities occur as a consequence of group level flaws or genetics that are different between those of us who are Black and those of us who are white. The differences that we experience in this country occur not because of anything natural, but because we made it this way. And the only good thing about that is that to understand that we made it this way means that we can undo it. Next slide. I'm gonna skip through most of this next step. So go through this, keep going, keep going, keep going. I want to show this slide, which looks at a family in Los Angeles. So this is an actual study of a family who had various issues that needed to be addressed. Next, push next. The various agencies that interacted with those families in order to resolve the issues that they had to deal with. And then once one of those issues was resolved, next slide, we returned families to the same circumstances that required the assistance and help of those agencies in the first place. Next. And this goes to emphasize next the point that Joe was making to us earlier, is that we have to figure out a way to take a social determinants approach, which challenges us to eliminate the obstacles and the disparities that people experience as a consequence of circumstances in life that place people at increased risk. Next, we're going to skip a couple of other slides as well. Next. I'm sometimes asked which social determinants we ought to address, and my answer is that we eventually have to address them all. But you start where you can find the most agreement in your community, the most strength in your community for dealing with things. And that's the core of the whole chat process, is that you bring your community together, you identify where there's a problem, and you figure out a way to address it. Next slide. Next slide. So this whole basic idea is that socioeconomic position, race and ethnicity and gender all structure the likelihood of multiple exposures at multiple points in time over the entire life course. Next. And it's this lifelong cascade of interacting multiple exposures balanced against available resources that are the important determinants of how social inequalities leave their imprint as health inequities. Poverty and race are intertwined, with each making the other worse, and racism, in my opinion, represents a particularly damaging and pervasive exposure. For the poor, I think it's the venom in the bite of poverty, that it's intricately woven into every domain of American life and has cumulative detrimental effects throughout an individual's lifetime, across all domains and across generations. Next. Now is the time for us to begin to address this. This embellishes a quote from James Baldwin back in 1989 when he was asked about our country dealing with racism. "You've always told me it takes more time. It's taken my father's time, my mother's time, my uncle's and my aunt's time, my sister and my brother's time, my nieces and my nephew's time, and before them it took my grandparents, great-grandparents, and great-great-grandparents' time. So how much more time do you want for racial progress?" This summer of unrest ought to remind us that now is the time for us to deal with this. Next. This is hard work, and it always seems impossible, but Nelson Mandela's life is an example that it can be done. Next. So thank you guys very much for this opportunity to present. Next, it's my pleasure to turn the podium, if you will, over to Dr. Kiera Barnett, who is a postdoctoral researcher at the Kirwan Institute for the Study of Race and Ethnicity. Kiera.
Thank you, Dr. James. And thank you everyone at the Franklin County Public Health Department who invited me here today to be a part of this talk. You can go to the next slide. If I could go you can skip this overview slide as well. And so a lot of my presentation today is going to overlap with Dr. James. I think great minds think alike. And I think we have a lot of overlap in terms of like what's really important when we have this conversation around social determinants of health and its impacts of structural racism. So when thinking about the social determinants of health, Dr. James kind of already went over this, is what they are and why they're important. But just here emphasizing that they're defined as the conditions in which people are born, grow, work, live, and age in the wider set of forces and systems that shape our daily life. And we can use this graphic on the right to kind of illustrate its importance. So we start at the very top with our health outcomes. So we can think of this in terms of the length of life and the quality of life. But when we think about what contributes to those health outcomes, we end up with these things that we see in blue, these health factors. And oftentimes we're kind of stuck in public health and healthcare, we're stuck in those first two tiers. So we're thinking about health behaviors, right? So as we're having this conversation now during this pandemic around COVID, we think about health behaviors like who's wearing a mask and who's social distancing and things of that nature, which are really important things to address COVID-19. We can also have conversations about the clinical care. So what access to testing does a person have? If they were to contract COVID-19, what kind of quality of healthcare can they receive in order to have the best outcome possible? And oftentimes that's where we stop our conversation. But it's really important that we also get down to those other two, that other half of what creates these health outcomes. So these social and economic factors. So one example in terms of COVID-19 is thinking about, well, what type of employment does someone have, right? Not only are they employed, but where are they employed? Do they work at a job that provides them with adequate PPEs that allows them to social distance from others, or are they in a work environment that's going to consistently place them at risk of contracting the virus? And then we also have to look at the physical environment, which is looking at the air and water quality or the housing. Again, an example of COVID-19 and thinking about the physical environment is, do you live in high, densely populated areas that again are going to put you in more, you're going to naturally interact with more people that will put you at a greater risk. And so we really have to think about, when we think about health outcomes, all of these different pieces if we actually want to see we want to see good health, but we want to talk about health equity, we have to think about those things. And then finally, in that orange box at the bottom is understanding that how all of these health factors are ultimately influenced by our policies and our programs. And we have to do an evaluation of how our policies and programs are positively or negatively impacting all those blue boxes. Next slide, please. So oftentimes at the Kirwan Institute, we are really known for creating maps and having this visual distribution of not only social determinants of health, but we also broadly talk about opportunity. So what access to different resources do different communities have? Next slide. And so I just want to walk through some examples using looking at Franklin County for some different social determinants of health. So what does it look like spatially? So this is looking at poverty. So here, as you see, the gradient gets, the colors on the map get darker. That's where we see large pockets of the population who is living below the poverty line. What's important to point out here, and oftentimes that I'm giving these presentations, we talk about this upside down T-shaped area that you can see where we see the darkest areas, right? So we see a lot of the darkest areas showing up in places in the city of Columbus, right? Rather than the outskirts of the county. But it's important to point out that we do see areas like Whitehall, areas near Worthington and Westerville, and even in the Hilliard area that have these pockets of poverty as well. And so oftentimes when we're thinking about Franklin County and we're including the city of Columbus, we forget or we focus on kind of where we see the greatest need in terms of these social determinants of health, but we also need to acknowledge that we still do have these pockets of disparity showing up in our more suburban areas. Next slide, please. This is another example of a social determinant. So looking at the built environment. So this is where we see food deserts. And so where we see these green areas are areas where we see a significant share of the residents the nearest supermarket for these residents are more than a mile away. Again, kind of that, the same areas where we saw the most poverty is also not a coincidence. So that's also the areas where we see our food deserts. Next slide. And this is important because when we think about also who has access to transportation, so this is looking at the percentage of households without a vehicle. And as it gets darker, we see a larger population without access to a vehicle. You know, if we were to overlay the previous slide with this slide, we would see that where we see our food deserts are also, unfortunately, where we see a higher percentage of population without access to a vehicle. This is also important to think about during this pandemic, as you know, public transit might have shifted and changed throughout this year in terms of the availability. Kind of, you know, we reduced public transit in a lot of major cities in order to decrease infection rates. But what impact is that going to have on communities and areas where folks don't have access to transportation? Again, thinking about what does it look like on the outskirts of the county in places like we see Reynoldsburg, where we start to see some darker colors as well. Again, we see Whitehall comes up, areas in Grove City. So thinking about what does public transit look like in those areas where we know we probably have a lot of public transit happening in our city cores, but in the outskirts of the county, what does public transit look like? Are we allowing folks in our most vulnerable populations at that access to get the things that they need during this pandemic? Next slide. And then finally, we can look at something like the percent of folks with access to health insurance. So this is looking at, as the colors get darker, it's a higher population without health insurance. And again, we see that upside down T within the county showing up, but again, we see pockets within certain regions on the outskirts that show up with higher rates without insurance. Next slide. So we can look at social determinants of health at the individual level. So looking at one social determinant at a time. We can also create different indexes that allows us to look at almost like an accumulative effect of these social determinants. So this is a example of one. So this is the Childhood Opportunity or Child Opportunity Index 2.0. This was done in collaboration with one of my colleagues at the Kirwan Institute and the Brandeis University. And so what they've done is taken different indicators. So they looked at some social and economic indicators. They looked at some health and physical environment indicators, as well as some indicators across education, and created this index to look at what level of opportunity do children have within the neighborhoods in which they live. And then they scaled those opportunities. So it starts at the very low and then kind of going up this gradient to very high. So as the colors get darker, you have areas with more levels of opportunity. And so this is what this looks like in Franklin County, but this is a project that they did for the 100 largest metro areas within the country. Next slide. And so if we take a look at like who's impacted by these disparities in terms of who has access to opportunity and who doesn't. So this is specifically looking at Columbus metro area, but it's looking at the breakdown of the racial ethnic breakdown of children who live in these different gradients of opportunity. So if we start at the very low, so the very low opportunity neighborhoods in Columbus, 11% of children living in those areas are white, compared to 34% of Hispanic children and 49. So almost half of our Black children in Columbus are living in these very low opportunity neighborhoods. And if you look at the very other end of the spectrum, so looking at this very high opportunity level neighborhoods, we have 24% of our white children living in those neighborhoods compared to only 11% of Hispanic children, and only 4% of Black children in Columbus are living in these very high opportunities. So as Dr. James talked about in terms of this life course effect of having access to resources, we see this happening here, where we see a lot of our children our children aren't starting off in the same place, and we have this disparity that's starting at a very young age in terms of access to different resources. Next slide. And if we look at what does this look like, not only just for Columbus, but actually across this nation, so across the largest 100 metro areas within the country, the numbers kind of get even worse, where we see only 6% of white children living in these very low opportunity areas compared to 32% of Hispanics, 46% of Black children. And if we look at the very high opportunity, 39% of white children in this country have the privilege of living in very high opportunity areas compared to 9% of Hispanic children and 7% of Black children. Next slide, please. So Dr. James already kind of covered this, but I think it's really important to just reemphasize kind of where these disparities originate. Next slide. So this is going to be an animation we're going to walk through. So we have these social determinants of health, which can fall within any of these buckets. So we have safe and affordable housing, having a living wage, quality education, and so on and so on. If you can click the animation twice. And if we think about kind of how does these social determinants kind of funnel down into inequities and health outcomes, well, we say that these social determinants have an impact on the psychosocial stress that people endure, and also whether they can engage in healthy or unhealthy behaviors based on their access to different resources. And it's those things that are ultimately going to impact their health outcomes. If you can click the animation twice. But if we take a step back and say, where do these social determinants and these distribution of social determinants come from? One more time, click the animation. Then we see these power and wealth imbalances that exist within our society. And we see this played out in our labor markets, our housing policies, our social safety nets, and so on. So think about, one example I'll give is for housing policy, some of the regulations around who has access to Section 8 housing, right? Or subsidized housing. So we have policies that state that, for example, a person who has an eviction on their record over the last, let's say, 8 years, can't have access to affordable housing. Well, that's our most vulnerable population, and they need the access to the affordable housing, likely because they've experienced an eviction and they've experienced housing insecurity. Yet our policies are set up in a way that, you know, further discriminates against people who are coming from disadvantaged backgrounds. If you can click the animation twice. So if we think about kind of what are those root causes, where do these imbalances in this power and wealth imbalances come from, then we end up with these root causes, which we can kind of cipher off into these three buckets. So institutionalized racism, class oppression, and gender discrimination and exploitation. So based on my expertise and our expertise at the Kirwan Institute, we focus a lot on institutional racism, but there is conversation that could be had about those other two buckets as well. Next slide. So I won't go over this because Dr. James already covered this, the same definition of understanding what racism is. Next slide. And then also understanding the three ways that it operationalizes. And Dr. James covered this really well as well. One of the things I would just want to add here is that oftentimes when we think about racism, when we hear that word, we're automatically triggered, and a lot of us really focus on that personal mediated racism. So we're thinking about the KKK, we're thinking about what happened in Charlottesville, right? So what's happening in the interaction between one person to the next. And that's typically how most of us kind of visualize what it means, what racism looks like and what it does. But it's really important to really understand that institutional racism, because what's important about that is that it exists without the existence of a racist present, right? And so it's embedded in our policies, it's embedded in our social norms, and the way that it's impacting our community continues to perpetuate regardless of necessarily who's in office and what their political views or their level of equity might be. Next slide. As Dr. James also covered, like we have to understand our past if we want to truly get a grasp of what's happening in the present and really plan for our future. And then one of the ways that we want to do this is really looking at historical policy, because we know that through policies where we're going to see the most sustainable change happening. And so I'm going to walk through really briefly 3 examples of historical policies that I often emphasize in these conversations around public health, because I think they're really important in understanding how our communities have been shaped and understanding the histories that's rooted in racism that have created our communities. Next slide. So the first policy I'm going to talk about really briefly is zoning. So zoning really did have a public health purpose initially. So essentially we zoned for the different land uses, particularly because we want to do 2 things. So one is so that I can't buy a plot of land today, build a house for me and my family, and someone can't buy the plot of land next to me tomorrow and build a factory. One that can have public health or health implications for me and my family, as we might be subjected to the fumes that's coming from that factory. And then also, because we are a capitalist society, we also zone for different land uses because we want to preserve our property value. So my house is no longer as valuable if it's built next to a factory. And so that's why we first initially began zoning. But unfortunately, when we create these policies, there can also be a negative use of these policies, and we saw that happening. We saw in the early 1900s in Baltimore, I believe was the first city that also used these zoning measures to specifically zone different neighborhoods based on race. So saying that this neighborhood is zoned for white individuals and this neighborhood is zoned for Black individuals. We also see zoning in some less obvious ways in terms of trying to parcel out who can live where within our communities. And one example is having a minimum lot size or building standard materials for an area. So an example is if I'm building, I'm gonna build a new or zone a new area for single family homes, I might say that every home in this plot of land needs to be built with a half an acre of land, right? And so having that in the zoning measure would automatically kind of cipher out individuals who come from lower economic statuses who can't necessarily afford to live in or to purchase a half acre of land. Similarly, we'll zone areas that everything built in this area needs to be a single family home. Again, that's minimizing or eliminating folks who might live in apartments or duplexes from moving into that area. Next slide. The second policy I want to go over is redlining. And many of you might have heard of redlining before, especially if you heard us talk at Kerwin, because we talk about it a lot. But redlining is this process to assess neighborhood risk to determine the eligibility to receive these federal loan insurance. So this happened in the 1930s and the 1950s. And essentially what was taking place at the time was we saw that many banks were crashing at the time. So this is right after the Great Depression. The way that the mortgages were set up during this time looked a lot different from what they look like now. During that time, mortgages were essentially set up so that the lender, the borrower, was paying monthly just to pay the interest. And at the end of the mortgage term, you were expected to pay the lump sum of the principal balance. And so we saw a lot of people defaulting on their mortgages. And so banks were crashing. And so the federal government stepped in and said, hey, we're actually going to back these loans, but we need to find a way to kind of ensure that the borrowers are actually going to pay back. And this is the 1930s and 50s. We don't have to argue about what racism in this country looked like during that time. And so a lot of this, rather than making assessments based on something that we do now, like credit scores, which also has its roots in racism, and we could talk further about that. But at this time, they were making the assessment at the neighborhood level, and it was particularly looking at the racial ethnic makeup of who was living in the area. And so neighborhoods were graded A through D. And what we know from the archival data around this is that those D-rated communities were our Black communities. And oftentimes the reason why they were rated D based on the scorecard that the neighborhoods received was because it was a Negro population living in those areas. And if you received a D grade, you were not eligible to receive any of your mortgage backed by this federal loan insurance, which oftentimes meant that individuals weren't able to get loans at all, or then they were subject to predatory loans because this wasn't an option for them to do the traditional route. This is important to know that this established our modern day mortgage, and then every bank or banks continue to use this practice in every American city as well. Next slide. And then the final policies I want to talk about is highways and urban renewal. And so as we saw white flight happening, and we saw the building of our suburban areas throughout this country, there was this need, obviously, to connect those suburbs to the inner city and downtown areas where a lot of people work. And so now we're constructing our highways, but that highway construction and renewal projects predominantly were impacting our low income and minority communities. And so what we saw was massive displacement. And this is an example of Atlanta, where 1 in 9 people were displaced because of the construction of highways. It's really important to note that this had financial and psychological impacts on the folks that were relocated. The psychological impacts is really what we know for low income and minority communities. One of their biggest resources is oftentimes one another. So the community that they build. And so as we were relocating individuals, we're also kind of ripping them from their social resources. That is also very important to their survival as well. We oftentimes saw that people of color were relocated to already overcrowded areas or new areas with high density public housing. Flash forward to 2020, again, we created these neighborhoods that were overcrowded. And now that we're in a pandemic, having those overcrowded areas is going to have an impact on our Black and Brown communities, who again can't properly social distance because they're living in such condensed housing. And then more homes were destroyed than rebuilt during this process. About 90% of the housing that was destroyed was not replaced. Next slide. And what's important to note is that these policies all worked hand in hand. So this is a map of a red line map of Columbus, and then the lines that we see are the highways that cut through the city. What's really important to point out here is if you kind of look at where these highways are going through, these different colors on the map. So those red areas are degraded areas. And you can see that almost all of the red line areas within Columbus were, there was a highway being built through those communities. And if you look at those blue and green areas, so those are our A and B graded areas where our predominantly white upper class citizens were living at the time, we see that, they were not touched when we created the highways. So our highway system beautifully went around our white communities and tore apart our Black and Brown communities. Next slide. And then that's not unique to just Columbus, and you can click one more time as well. The way that the highways went through redline communities happened at the nationwide level and also across the state of Ohio. And so on the left, we're looking at what does it look like nationwide. So if we look at the percentage of highways that went through communities that were HOKA assessed. So if we had, that the map I just showed, but for all the cities that we have maps for, what percentage of highways were built through which of the communities, we see about 47% of redline communities had highways built through them, compared to only 3% of those A-graded communities as well. And if we look at Ohio, it's a little less. We see in the state of Ohio, most of our highways were cutting through our C-graded communities. That C-graded communities were also often low-income immigrant communities during the time. So again, during the 1930s and 1950s. But we just see that our highways also cut through our Black and Brown communities. Next slide. And so if we think about kind of why does this matter now, we're 70 plus years later, kind of why does this even matter? Why is this history important to talk about? Next slide. It's important because we created the system of segregation that persists today. So this is looking at those historically, A through D graded neighborhoods. And this is looking at what was the income of folks living in those communities present day, or in this example, it's as of 2016. So if we look at our A-graded communities at the national level, 91% of folks living in those A-graded areas today are still, that MUI stands for middle to upper income. And 74% of folks living in those historically degraded areas are low to moderate income. Next slide. And if we look at the racial breakdown of who's living in these communities at the national level, 85% of those living in historical A-graded neighborhoods are white. And in our D-graded neighborhoods, 63% of them are minority. Next slide. And we can look at what does this specifically look like in something like Columbus. And if you want to click the animation, please. In Columbus, our historically A-graded communities, 91% of folks living in those communities today are white, and 89% of them are middle to upper income. And in our D-graded communities, 47% of them are minority, and 82% of folks living in those historically degraded neighborhoods are still low to moderate income. Next slide. So now shifting the conversation to how does this all impact health equity? Next slide. And we got a question in the chat around kind of explaining the difference between equality and equity, because I think that's really important. And oftentimes we hear those words being used interchangeably, but the reality is they mean completely different things. And so if we start looking at this graphic at the top left, so we have this inequality, right? So if we look at the tree, there is something structurally wrong with this tree, right? We can see that it is leaning to the left. And so the kid on the left can get an apple without really even trying, right? Because there's something structurally wrong where the resources are falling into his lap, where the kid on the right doesn't seem to have the same access to the resources. And if we specifically look at the tree itself, we also see that there's a uneven distribution of apples from the left side of the tree to the right side of the tree. So we can have a conversation about, equality. So equality is giving people the same, the same resources, the same tools, and expecting the same outcomes. So in this example, we gave both kids a 6-foot ladder, right? That allowed the kid on the left, because there's something structurally wrong with the tree that's making it lean to the left, it allows him to access the tree even easier. So he already had resources falling on his lap, but now he can access resources even more because we've given him this tool. But the child on the right still doesn't have access. Even with that, giving them the same tool doesn't fix the problem, because there's still this structural inequity. So if we get to the bottom left hand where we talk about equity, now we're talking about giving people, customized tools to get them the same outcome. So here, maybe the child on the right needs an 8-foot ladder. So now that child can reach the tree and can get some apples. The problem is if we stop the conversation there, right, there's still something structurally wrong with the tree. And because of that, there's more resources on the left side of that tree than the right side of the tree. So really we have to shift our conversation to not only figuring out how do we get equity, but how do we get justice? So how do we start to also fix what's structurally wrong? So in this example with the tree, now we're gonna use these boards to straighten the tree. And by doing that, by fixing the structural inequities that exist, we now see that the apples are growing on both sides evenly. And now with the same equal resources, so now both children can reach the tree with a 6-foot ladder. So we don't have to give these customized tools to different children, because we fix what's structurally wrong with the tree. Next slide. So thinking about health inequities, and it's linked to social determinants, but also it's linked to this history. So this is 2 different maps. So one is looking on the left at infant deaths, and this is from 2007 to 2011. But important to note that these areas haven't necessarily shifted too much over the last 9 years in terms of where we're seeing our highest infant mortality within the county. So it's really important to see that, or notice that we see that same upside down T that we saw when we were looking at maps of social determinants of health showing up when we look at health outcomes as well. So there's this connection between communities and areas where we see inequities and social determinants, and then where we see inequities and health outcomes. And then the map on the right is looking at life expectancy. And so as the colors are green, that's where we also see lower life expectancy. And so we know that we have this gap in life expectancy here in Franklin County, based on where you live. In areas that are very close proximity to one another can have very different life expectancies. Next slide. It's important to note that there's also this research around kind of what is the stress of living in communities with low resources, and how can that have impacts on your body and on your health. And so essentially we are supposed to experience stress. Stress is a natural function in our bodies. We're supposed to experience a stressor, have this behavioral response, this fight or flight kind of sense that's supposed to trigger sociological response within our bodies, but then we're supposed to kind of go back into homeostasis. But what happens for folks who are living in these low resource communities oftentimes is that they're experiencing this chronic stress that's having this wear and tear on their body and putting them in what's called allostasis, or having this high allostatic load. We know that high allostatic load has been associated with diabetes, hypertension, obesity, and other health outcomes. Also, other mental health outcomes like having anxiety or having depression. And so this research is kind of making the connection between what's happening on the outside in your environment also is having changes and impacts on what's happening inside your body biologically. Next slide. And so finally, thinking of a call to action, kind of what can we do and where can we go from here? Next slide. So first, and I always say this in all my presentations, is we have to start to figure out how can we think beyond the individual. So oftentimes we think that the problem is, are the people, but we have to pay attention to that it's the systems and the environment in which they live that's causing these health disparities, not the people and and the actions or inactions that they're taking to have better health. We also want to assess present day inequities within the areas in which we work and we live. So one is understanding not only, so what are the gaps, but then taking a step back and say, well, what are the drivers behind those gaps? Because that's really important to, again, to get to the root cause of what's happening within our communities. Next slide. And then finally, we want to understand the histories within our communities that have created these current conditions. So as Dr. James mentioned, the example of if you want to learn how to untie a knot, you first have to learn how to tie it. It's the same thing. We have to understand what happened in our communities to figure out what it is that we have to undo. And then we need to call attention to those past injustices, and again, in order to properly address them. We also want to address the social determinants of health within our communities. Teresa gave a great presentation of the health equity in all policies and what that means. To Teresa's point, now that I'm reading the slide, it should say health and equity in all policies, because I think as both Teresa and Dr. James pointed out, is that we want to have health equity, but we also want to have equity, in everything that we do. And we really want to take a step back and understand what are the unintentional consequences of the policies that we're creating. And then we want to address, as we have COVID relief dollars or other grant dollars coming in, really taking a time to assess where they're going and how we're allocating funds to different communities. And then finally, is collaborating with other agencies and community members to address those gaps and their causes, and using this multi-level approach. I always say that, a lot of the information that I presented here today, I learned through my collaboration with my colleagues at the Kirwan Institute who don't have a public health background, who don't do work in public health, but I think it's really important for us to have these conversations collectively across agencies and across fields, because the things that they learn and the things that they do are ultimately having an impact on the health of folks within our community. And it's really important that we start to have a dialogue and figure out how we can co-create and collaborate in order to address some inequities. Next slide. Yep. And that's all I have for you. Thank you, everyone, for attending.
Thank you so much for those wonderful presentations, Dr. Barnett and Dr. James. Dr. James, if you could please join us again. We will now have about 20 minutes for questions and answers from the audience. So we can begin with our first question. And this will be for both panelists. Can you talk about the differences in how to approach equity when working with communities that have been impacted by inequity, particularly minority communities? We'll start with that first question. And we'll start with Dr. Barnett.
Do you want to start, Kiera?
Oh, you can start.
Okay. I tried to put some general principles in the chat box in response to some of those questions. Where I'll start with this one is that I think in general, and this is just in general, I think there are three general principles that we have to take into account all the time, and that it helps us from both a moral and a practical approach to trying to figure out how to address this stuff. And one is that it's important that we value all individuals and populations equally. Second is to recognize and rectify the historical injustices associated with racism. So that whole notion of tying and untying the knot. And three is, the fancy term for this is proportionate universalism or targeted universalism, but the importance of providing resources according to need. So I love the slide that Dr. Barnett used where she showed the apple tree, that our goal is to achieve justice, so it goes even beyond equity. That's extremely important. I'll stop there.
I'm sorry, quick A quick follow-up question for you, Dr. James. Can you speak a little bit to targeted universalism? You had mentioned that in your response.
Yeah. So in general, it's providing resources according to need. So an example that I sometimes will use is we talk a lot about differences in life expectancy for different populations and different groups. And let's say from a public health perspective, our intent was to have an equitable life expectancy for everyone, no matter what your race, no matter what your socioeconomic status. That means then to achieve that this isn't a conversation about have and have nots, but it does mean that we're going to provide most of the assistance and help for achieving the level of life expectancy that we would like. We're going to provide most of that assistance and help to the folks who are dying at much younger ages. They're going to get more help than the help that we provide by those communities, or to those communities that let's say have a life expectancy that is 20 years more than the community most adversely affected. But it's not just providing assistance and help to the poor performing community, but it's to everybody in between, and the level of assistance and help that's provided to those individual communities will depend on the amount of assistance and help they need to achieve whatever the goal is. An example that I use in infant mortality is that, most recently, the feds have released our Healthy People 2030 goals for infant mortality. And those goals indicate that by the time we get to the year 2030, we want to have an infant mortality rate for everybody of 5 infant deaths per 1,000 live births. Well, in the state of Ohio, our most recent Black infant mortality rate is 14 deaths per live Black births, whereas it's 5.4 for whites. So it means then that we need to provide more assistance and help to Black communities in order for us to achieve that Healthy People 2030 goal than to white communities. It doesn't mean that we don't provide assistance and help to the white community, because 5.4 is not 5, and we want to make sure that they achieve an infant mortality rate of 5 by the time we get to the year 2030. What we've done in our state instead, historically, is that we've ignored the Black infant mortality rate. So that if you look at now the 4 decades of Healthy People goals where infant mortality is concerned, in those 4 decades, we've achieved the white infant mortality rate goal, and we've achieved it in advance of the goal date for 3 of the 4 decades. But we have never, not once, achieved a Healthy People Black infant mortality rate goal in the state of Ohio. That's a pattern that we have to change.
Thank you so much for that elaboration. Dr. Barnett, would you like to follow up?
Yeah, I'm thinking to the original question around like, how do we have these conversations around health equity in communities that have been experiencing these inequities for a long time? I think one of the things that we have to learn to do is also involving the community directly in the work that we're doing. So giving them voice and giving them, empowering them to be a part of the process as we're trying to address these inequities. So learning from firsthand from folks in the community, what issues they are experiencing, what issues would they like to address, and having them a part of that problem solving, I think is really important.
Thank you so much. Our next question, how do we get people to work upstream with the social determinants of health to stop blaming people for their diseases? I'll go back to you, Dr. Barnett.
Yeah, I think what's really important around that is educating people on that history of what social determinants of health are, and then how it's so influential into our, not only our health, but also the way that our communities look. I think oftentimes it's easy for us, if we think about implicit bias a little bit, which I didn't really get into a conversation about, we make assumptions about people and about situations because our brain is trying to, fill out incomplete information. So if we don't know what's going on in a person's house, household or in their neighborhood, but we just see the individual, we're going to make all of these assumptions about what that person does, right? So sometimes it's about filling in those blanks with, one, measuring individual social determinants of health. So if you're doing work within a community, or you're working at a health clinic, for example, in the community, and you're seeing patients constantly that are experiencing similar health outcomes, so you start to think that these people might be, you blame the individuals that they're engaging in some sort of behavior, they're being unhealthy, and that's why they have these health outcomes. But if we start to also in our systems embed these social determinants of health, that we have to collect this information, we have to think about it, then it also can show people how all of these things are connected, if that makes sense.
And this is Arthur. One of the things that I'd like to add to that conversation is that one of the challenges that I think we have, a huge portion of the challenge that I think we have, is that despite living in a country that that is very ready to acknowledge its origin, the wonderful victories we've had in terms of various wars, the inventions that we've made, the stuff that we've done that quote unquote makes America the greatest country in the world. Where racism is concerned, we behave as if we are a ahistorical country, meaning that we refuse to acknowledge racism and how it's adversely influenced various populations, and that's a piece of what we have to change. I think it's one of the reckonings that have occurred in our country as a consequence of the racial unrest that was experienced over the summer. But that's just the beginning of this. While witnessing George Floyd's death and the way he was murdered, I think has helped to awaken a lot of people in our country, especially white people who perhaps thought that we were a post-racial nation, that we've been reminded that we actually live in an apartheid America. And we have to own that and be willing to address it and do something about it. I'm going to go on here a little bit because there are some questions in the chat that ask about this issue of racism as it pertains to other groups, and it certainly does. Indigenous populations in our country were almost totally eradicated as a consequence of racism, and they've been marginalized, if you will, to reservations where we've treated them very, very badly. It's a piece of things that we also need to help this country recognize and address, and the way we treat other ethnic minority groups. Think about the many children in our southern border who have been placed in jail-like conditions and separated from their families, but not only that, separated in a manner where we haven't developed a mechanism for reuniting them with their families later on. That's racism. The way we've treated Muslims and people from other countries. It's a horrible thread that runs through our country. And yes, in our examples, we've emphasized the notion of how our nation has treated African Americans, but it goes across the board for any number of ethnic minority groups, and it's a piece of what we have to pay attention to.
Absolutely. Dr. Barnett, did you want to elaborate on the follow-up question? I know Dr. James addressed it, but just can someone address how racism impacts other minority communities in addition to the Black experience that is clearly pervasive and destructive to health and general well-being?
Yeah, so essentially everything that Dr. James said is absolutely true. I think oftentimes we default to the Black experience because it's something that has been so pervasive in our history. And it's also been something that like we have, not saying that we need documentation of racism to know that, if it exists or not, but it's one of those examples where, looking back at the policies that I gave, we have explicit examples of, racism embedded in our policies against Black populations. But that's not to say that they're the only ones that also, they're the only ones that were experiencing the negative impact of those policies as well, because they also had influences on other racial and ethnic minorities as well. I've done some work around premature births and low birth weight among Arab American women here in the state of Ohio. And one of the things that we were looking at, we didn't actually look at neighborhood level conditions, but one of the things that we started to do is kind of like map out where do we see these higher levels. And we did see almost like this clustering effect where when people were living in more densely populated areas with other, Arab American citizens, that's where we saw clustering of worse birth outcomes within these communities. And it's not because living next to other Arab Americans is going to influence your health, but it's probably about like what the resources or lack thereof of resources in those communities might be. So we've looked at that at the Kirwan Institute. It's one of the things that the Kirwan Institute is making some shifts and stuff in terms of what we research around making sure that we are including these other minority groups in the work that we do.
Thank you so much for that. Last question from the audience. In recognizing that health behaviors are typically learned from someone's social settings, be it family or home, work, or family life, what is being done to combat that with education in the public school system? And actually, I'll start with Dr. James.
Oh, I think that's such a rich question. So if we just deal with things from a health perspective, one of the things that I think is amazing about the state of Ohio is that where in our primary school system, we struggle with offering health education classes within the public school system in this state, so that it challenges us to provide, for example, or the mechanisms to prevent infant mortality are concerned from a clinical perspective. It challenges us to provide the adequate education to people coming up. But more generally, where the whole issue of racism is concerned and how it influences things and how our educational system might impact that, to tell the truth about our history, how these conditions came to be, instead of perpetuating the false tales that we suggest. We endorse in this country this false notion of human hierarchy that suggests that some of us are better than and more deserving than others of us. And in the process of doing that, what we do for ethnic minority groups is that we subject them to a process of what John Powell refers to as othering, where we make them different from the majority group. And as a consequence of the difference that we create, we suggest that the more compromised outcomes that they experience are a result of those differences. Well, none of that's true. And we have to fight back that tendency in our country to deal with that. And it's a huge fight. Think, for example, about how aggressive the attempt was during this most recent presidential election to prevent communities of color from voting. And then in the midst of a COVID epidemic, to suggest that mail-in ballots weren't going to be valid, that you had to go risk your life and stand in line for long periods of time. We tried to get rid of mail processing machines in the post office, so those mail-in ballots might not reach poll places in time. And then even after the election, we have this suit going to the Supreme Court by 18 different states trying to invalidate votes from those swing states to in fact suggest to a whole group of people that their votes don't count. It's a crazy time in this country. Racism has risen its head in a way that many of us had not anticipated, and we've got to have the courage to stand up and address it.
And I would just add to that in the question, as Dr. James already mentioned, we don't really have health education standards in our public health systems here in Ohio. But as this person also, illustrated in the question itself, our health behaviors are going to be influenced by, our home life, our work life, and, all these other things that also are ultimately influenced by these social determinants of health. So we can set up these education standards. So I can go into schools and teach children how to engage in healthy behaviors. But if they leave that school and go back into an environment that doesn't have any of the resources they need to do all of those things, then it's not helpful. So we have to also make sure that we're not just teaching people what to do, but we're also giving them the tools and resources they need to actually get it done.
I totally agree.
All right, thank you so much for that. We actually have time for one last question, and one more just appeared in the chat box. So has any data been analyzed for the Asian immigrant and refugee communities that live in the areas affected by the social determinants of health? AACS has found that there is a need for those Asians living in these areas. Many are from the Southeast Asian refugees who have come here in the 60s.
So I can't think of any explicit examples of any work that we've done at the Kirwan Institute looking at that. Sorry, I'm trying to rattle my brain to think of if there's been some other work by other folks. I don't think so, but I think that there's definitely the need to do that, especially we know that we have a large immigrant communities here in Franklin County. So there's definitely this need to specifically look at those populations.
Yeah, I'm going to totally agree with that. I think that there's a substantial need, and we've proven this over and over again, to make sure that we disaggregate data that we look at on a racial basis, that how any group is doing is only going to be discovered when we do that. Now, having said that, I don't know local data regarding our Asian Pacific Islander population. However, I would refer you to the Ohio Commission on Minority Health, which in fact has an Asian and Pacific Islander subcommittee or subgroup, if you will, that pay more attention to that data than I am aware of.
All right, thank you both so much for your wonderful presentations. Oh, I see that we do have one final question, but unfortunately, we are out of time to be able to address it. I would recommend that you please reach out to our presenters. We can post their contact information at the end of our presentation. So we will move on to our final break. First, thank you so much to Dr. Barnett and Dr. James for joining us today. And thank you to our audience for asking such great questions. And we will break for before we go to our final segment. Thank you.
To be white in so many ways is to be raised to be functionally illiterate on the topic of race. I am white, and part of being white is that I was not raised to see myself in racial terms. I mean, I understood that somebody had race, but not really me. To be white is to see oneself outside of race, to see oneself as a unique, special individual, exempt from the forces of socialization. I'll never forget a moment of standing beside a black man leading a workshop on race, and a white woman said to him, "I don't see color." He said, "Well, then how are you going to see racism?" "Because I am black. I do think you know that, and I have a different experience than you do. And you're not going to be able to understand that, and you're not going to be able to support the parts of that experience that are really painful and problematic if you refuse to acknowledge my reality." I don't see color is really a way of saying I refuse to acknowledge your reality. What's important about that narrative is it reveals what the person thinks racism is. So if the person is using proximity, fondness across race as evidence of a lack of racism, in order for that to be good evidence, a racist must not be able to do that. So that rests on an understanding that a racist cannot tolerate proximity to people of color. And I'm hoping that we can see that's pretty absurd, because trust me, even avowed racists can tolerate being around people of color, and often are. You cannot talk about any other issue without talking about how race informs that issue. And when someone says it's about class, that tends to function as a way to get race off the table. First of all, we're already divided by race. And focusing on race is not what did it. I would say not focusing on race, refusing to grapple with how race shapes virtually everything is what keeps us divided. And that is a very white narrative. All of those narratives function to get race off the table, close the exploration, exempt the person from any further engagement, and protect the racial hierarchy and the white position with it, which is an unequal hierarchy. The challenge I want to offer my fellow white people is changing the question from if to how. So dominant culture asks if I'm racist, and I want to change that question to how have I been shaped by the forces of racism? How is racism manifesting in my life? Because it circulates 24/7, 365. None of us can be, and none of us were exempt from its forces. And this is where individualism can come in. I have a particular story, but that story didn't exempt me. And so I can ask myself, how did all the things I see as unique about me set me up into the overall racist structure? Because it did.
Well, good afternoon and welcome back to our panel discussion about voices from the ground, moving from theory to practice. My name is Lisa Den, and I'm going to be your moderator today. Panel goal is to learn more about the experiences and effective tools of those actively working to dismantle structural racism in their communities. I will take a few minutes to introduce our panel and then move into the main Q&A period. Following, we will have 15 minutes to take questions from the attendees. As panelists answer the prepared questions, please think about questions you have for them to be addressed after the main Q&A period. I'd like to take this opportunity to introduce our panelists. Catherine Plank is the Associate Provost for Curriculum Teaching and Learning and Mission at Otterbein University. Dr. Plank coordinates Otterbein's Truth, Racial Healing, and Transformation Campus Center. The center works in partnership with Columbus City Schools, and Westerville City Schools is part of a comprehensive national and community-based process to plan for and bring about transformational and sustainable change to address the historic and contemporary effects of racism. Malik Moore currently serves as the head of school for Columbus Preparatory Academy and is committed to affecting change and strengthening community in Columbus, Ohio, and throughout the world. As a mentor and work development coach, he dedicates time to serve students in Columbus City schools. Mr. Moore mentors nonprofit executives and YMCA professionals throughout the world and believes that through mentorship, coaching, and intentional relationship building, communities can become more closely connected, even during today's polarizing climate. The third panelist is David Norris. He is an epidemiologist with Franklin County Public Health, and it's a pleasure for me to say that he's a wonderful colleague to work with. He is also he's also a trained presenter for the Climate Reality Project, CRP, an internationally recognized nonprofit organization involved in education and advocacy related to climate change. He was trained in CRP's 2017 trainer cohort in Atlanta, Georgia, the organization's first such training dedicated to environmental justice in U.S. cities. Prior to joining FCPH, Mr. Norris worked for over 20 years in Columbus area organizations committed to social justice, including the Children's Defense Fund of Ohio and the Kirwan Institute for the Study of Race and Ethnicity at the Ohio State University. Welcome, panelists, and again, good afternoon, attendees. We're going to have several questions, panelists, for all of you, and then we are going to have several, which each one is dedicated to a panelist, which I'll call your name before I ask the question. For each question, you will have approximately 1 to 2 minutes. The first question for all of you, beginning with Dr. Plank, and then Malik Moore, and then David Norris. Please tell us about the work you do or have done addressing racism and equity in the community. You have 2 minutes.
Thank you. Excuse me. Thank you. And I'll first note I have no idea why my background is backwards, so I'm sorry about that. It looked right earlier. I'm here for my role working with the Truth, Racial Healing, and Transformation Campus Center we have at Otterbein. We were the first in Ohio, and we're still one of only 2 of these centers in Ohio. It's part of a larger national effort that came out of the Kellogg Foundation, developed by Dr. Gail Christopher, who has a health background. So even though I'm looking at this from an educational perspective, I've been struck all morning knowing how aligned what you're doing is with what we've been doing. Okay, so apparently my background looks okay. For me, it's backwards. So I wanted to just give you a quick discussion of what the TRHT movement is about and how this fits in with what you're doing. So our campus center, again, is this Truth, Racial Healing, and Transformation movement, which is based on some of the methodology of the truth and reconciliation that's happened in other countries. And it's these 3 principles. So truth, the importance of getting the true narratives out there, both current narratives. So part of our project is an oral history project to hear different people's experiences. We've all experienced the world differently, and to capture some of that. Our focus is on educational systems, so getting people, both students at our school, but at other schools and throughout the school districts, and people who've gone through those schools. It's also a history project as part of the truth, because we need to understand how this develops. And so I was interested in Dr. Barnett's maps. We've used a lot of those maps ourselves, the redlining, the effects on, there are similar maps looking at educational attainment in the county that follow that same upside down T. There are looking at how school districts were desegregated and not really desegregated, and the ongoing impact of things like the win-win agreement in the county. And so looking at how this system has continued to shape in the long-lasting legacy of racism that shapes our current educational experience as well as experience otherwise. The racial healing part of TRHT is done predominantly through racial healing circles, which I think I'll be talking about more in a little bit. Again, that's a methodology created by Dr. Christopher with the idea of really helping people engage with each other, to make human connection, to truly listen to other people's stories and narratives to understand them. We're we're doing a series of them this month, and I can at the end give you a link that you can sign up for them. We can also work with, if different chats want to set up some of these circles in their community, we would love to do that. And then the transformation part is we want from what we get from all this to lead to some really sustained transformation, to make the changes that in the system. And so thinking about that apple tree again, how do we help straighten up that tree for it to bring true justice and not just be providing ladders to make things equal, referring back to Dr. Burnett's talk. And so we're looking at things she mentioned. So, if we're looking at schools and the way school districts are shaped around the neighborhoods and the tax structure, et cetera, and what's the lasting impact of that on that. And so that is the work we've been doing. And we're doing this throughout the region. So even though it's Otterbein, Columbus, and Westerville, we're working, our whole idea is throughout Central Ohio.
Did you want me to go ahead and speak?
You're on mute, Lisa.
My apologies. Mr. Moore, sorry about that. Thank you, Teresa. Can you go ahead and answer the same question, please?
Yeah, my name is Malik Moore. I grew up in Philadelphia, and although I grew up in a community that would have definitely been listed on the redlining map, and I could tell a story of my father who came back from the war in Korea to be relegated to the colored community. I had many opportunities that others in my community may not have. I happened to have taken tests well, and because of that, that got me access into a lot of spaces that afforded me opportunity. I made a mistake. I think a lot of people who were born into a situation like my own, where initially my main goal was to assimilate into the popular culture and to be the best representative of the African-American community I could be. Somewhere along that process, I learned that my job was not to be a voice of the voiceless. My job was to reflect and recall all of the opportunities and privilege I had that may have contributed to taking away the amplification of the voices that were speaking about their own lived experiences, but speaking in a way that systems couldn't hear them. So somewhere along the way, I had to understand that my job was to no longer be a gatekeeper. My job was to get out of the way of those that were experts in their own lived experiences and help to uplift or help to change systems within organizations where I may have had a small sphere of influence. And so when I spent my time working for the YMCA, I'm very proud to have been part of the development of a national diversity and inclusion training protocol that would allow African-American leaders within the Y who were often limited from that one thing that would help you in job advancement, training opportunities. We began to intentionally look at how we built the pipeline of African-American leaders so that, again, that the voice could equitably be shared across the nation of those who were serving this very effective nonprofit, weren't serving in a manner of being a gatekeeper, but were really beginning to get out of the way of those with the expert lived experience. I've spent a great deal of time working to develop language within myself through the nonviolent communication process. Developing this language has helped me to then change my actions, and changing my language and my actions has helped me to change my values and measures. And so I come today as a person who has made many mistakes along the way. I'm a lifelong learner, and I'm here today to listen and learn as well, but very optimistic about what we can do if we come together in a collaborative spirit as a community. So thank you.
Mr. Moore, thank you. Mr. Norris, please. David?
Yes, Lisa, thank you so much. And thank you everyone for allowing me the opportunity to be here this afternoon. I am an epidemiologist at Franklin County Public Health. I work on the Overdose Data to Action CDC grant on the opioid crisis. But today I'm speaking primarily in my role as a presenter for the Climate Reality Project. And I'll say a little bit more about CRP in just a little bit. I describe my role, what I do in that role is primarily an aggregator and a disseminator and a translator. I aggregate a lot of information, primarily about climate change, but also other forms of environmental pollution and environmental racism, aggregate it, interpret it, and then disseminate that information to people who need it. And so in that spirit, I'd like to start by starting this piece of my part of this program today, the way I would start one of those presentations, which is with a land acknowledgement. I want to begin by acknowledging Central Ohio as the traditional homeland of the Shawnee Nation, Miami, Wyandot, and other indigenous nations who have strong ties to these lands. Today, individuals from the broad range of indigenous backgrounds call Columbus and Central Ohio home. And then I want to take it a little bit further and add another kind of acknowledgement to it specific for this kind of venue. I recognize that, like all of us, I'm a product of the culture I was raised in. As a white male, I've been insulated from the insults and injuries inflicted on others because of their race, gender, culture, or faith identities. And I do that because today I'm going to touch on life experiences that are not my own. And so I want to do so in humility. I want to maintain an attitude of listening, of respect, with, an attitude to learn, and finally with an attitude to leverage my privilege to benefit others. So that's the way I would start. And just a little bit about my work. I'm not currently engaged in doing climate work, research per se. I would say that most of my experience in this realm has come from my experience at the Kirwan Institute. I cherish that time, and I really value the time that I spent there. It was about 6.5 years. Worked with both Dr. Barnett and Dr. James during that time. And during that time, I was primarily focused on health equity, but also on environmental racism and environmental justice. And so I worked on a few projects. I was in Birmingham, Alabama for a time, working with community advocates there to support them in their work to prevent a rail line from being established in a low-income community, an African-American community that was going to carry toxic waste through their neighborhood. I worked for a time, probably about 3 years in Toledo on lead poisoning, helping to pass some legislation there to require inspections of homes before those homes can be rented to families with children. I worked on the Columbus Infant Mortality Task Force. I'm a geospatial analyst by training, and one of the maps you saw earlier was a little bit familiar to me. I actually worked on that, so that was kind of cool to see that. And I spent some time on Pine Ridge Reservation in South Dakota. And if you want to see what the third world looks like without leaving the United States, go to Pine Ridge. Having said that, I would also say that it's very important, whatever community you're in, to not succumb to and embrace the deficit narrative that might be told about your community, because even though we're talking about physical assets, there are also human capital assets in those communities, and that's really what we're all about with the chats today. So I really want to keep a focus on that dimension as well. I did get my training in Atlanta with the Climate Reality Project. As Lisa said, it was the first training of that kind to focus on racial equity and environmental justice. And so some of what I say a little bit later will come out of that training.
David, thank you for that. I think your points about your community work are well taken, and it's a good segue into our second question. What are some things that people can do to address racism in their communities and work towards equity? Mr. Malik Moore. Mr. Moore, you can go first. Thank you.
All right, I just needed to unmute. And so I'd say pause, reflect, and build, right? Pause first, because we're in such a, we have an affinity, a bias towards action in our community, and sometimes pausing first, not doing what might be the norm or what might be paced by normal policies or practices, but pause first and reflect to ask ourselves if what we're doing is furthering an agenda of equity, or is it furthering a norm that was created before the majority of us had the ability to look through a lens of what equity is, and then work in a different way to build, using our circles of influence to identify who our allies are, and allowing whatever privilege we might have the opportunity to bring more people to the table that are, again, experts in their lived experiences that can now speak to what changes or what systems might need to be updated or innovated to reflect what they need for that successful outcome. So equity to me is starting a process with the outcome we want in mind. And so as we experience racism, that's the opposite of that, right? Racism is we're going to do to people and have power over. But if we pause, reflect, and build, allowing ourselves to create opportunities for power with and not power over, I think we begin to get closer to that. The other piece I want to put in here is that we're never going to fix anything if we're not operating in a collaborative framework. And by collaborative, it can mean ourselves and another person. It could be interdisciplinarian. It could even be inter-organization. But we won't be able to do it on our own. We looked at the work that was laid out today by Dr. Barnett, by Dr. James, Teresa Seagraves, and what we see there is just patterns of doing things the old way, but being surprised when the outcomes don't look to be what we now define as equitable. So pause, reflect, and build. Thank you.
Dr. Plank, can you answer the same question, please?
I would reflect a lot of what he just said. I think I'm going back to Malik Moore's first statement of talking about really being able to listen and amplify the voices of people who have expertise in their own lived experiences. And that, again, is part of what we're trying to do to get the narratives listened to. So I would say listen to add to his verbs of things to do, and like truly listen. And that's a lot of what our TRHT is based on, that kind of listening, but also challenging. And so the narratives that we have and the narratives that have shaped a lot of decisions and a lot of the structures, and to realize like some of the narratives we tell about, why people live where they live, and that there's, we need to understand and do the history to question those and to start maybe deconstructing and getting past. I was noticing earlier, Dr. James mentioned the hierarchy of human value, and that's another principle TRHT is based on, this idea there is a hierarchy of a false belief in a hierarchy of human value, and we need to dismantle that. And we do that by, again, I think challenging narratives and then truly listening to other narratives so we can reshape what we're doing.
Thank you, Dr. Plank. David, same question. You're on mute. David, you're on mute.
Not sure how that happened. Yeah, I would agree with everything that's been said. I mean, it's important to listen. It's important to be an ally. I think I would also add that, and I'm going to speak specifically from my experience as a white male and as a white person, to be an ally, to stand beside, and that can take, that can be done on a personal basis at work. You can be an ally to your Black colleagues by lifting up the work that they're doing. You can actively speak out against microaggressions when you see them occurring. So interpersonal, interactions like that. I would also say too, if you are white, always look for ways to leverage your privilege. And if you're a person who has any kind of privilege whatsoever, but I'm again speaking specifically of white privilege, look for ways to leverage that. One of the final presentations in the Atlanta training was the panel discussion, and at one point, a Black woman on the panel looked at the audience, which was largely white, and I'll have a little bit more to say about that in a little bit, but she was very direct, and she said to folks in the audience, if you are white, this is what we need from you. We need your privilege, and we need your money. We need your privilege, and as Mr. Moore was saying, it's not about coming in and doing for. It's about lending your power to others. It's about empowering others, giving access, providing support so that their voices can be heard, and that their influence can be had in whatever space you're in. And there's a tremendous wealth gap in this country. It goes all the way back to the things that Dr. Barnett and Dr. James were speaking about earlier. It's historic, it's longstanding, and white privilege also includes access to resources that a lot of people of color do not have. And so financial support is an important thing to do in this realm.
Thank you, David. We're going to move on to number 3, and Dr. Plank, you will get this first. It's a two-part question. What are some challenges that community members may face in addressing racism in their communities? First part. Second part, what are some effective ways to respond to pushback or resistance to change in dismantling racism?
So those are big questions. I think where a lot of the resistance can come from is we are still a very segregated society. You can look at, those maps that we were looking at earlier just show how the legacy of that has just continued, and you can just layer those maps one on top of the other, and those boundaries remain pretty consistent. Even when you look at things, I included a map of things like internet access. It's exactly that same the same shape of where we're segregated. And so I think one of the things when you're in your community, I'm sure a lot of the communities represented here are also very divided in some ways, whether it's a road that creates a boundary between two neighborhoods or schools or other ways that we're segregated. And so one of the challenges is people often don't see across that road, and they don't, that people assume their experience is everybody else's experience. And so as part of the second answer, I'm looking for ways that we can really work across some of those boundaries and find ways for people to really be able to, and I'm going to use that word, listen again, and listen and really understand the lived experiences of others. And so having activities and having different kinds of opportunities to work across those divisions, I think, is one of the solutions we're trying to do.
Mr. Moore, Malik Moore, can you take that question next? Would you like for it to be repeated?
Oh, I would love for you to repeat it, and,
Sure.
and I'm ready to answer, yes.
Sure. First part, what are some challenges that community members may face in addressing racism in their community? The second one is, what are some effective ways to respond to pushback or resistance to change in dismantling racism? Thank you.
Excellent. The challenges. Racism is pervasive. It's everywhere. Many times folks are intentionally racist or involved in acts of racism, and sometimes they're passive participants in perpetuating racism from their positions of power within systems. And so I think there's an important part of us to understand how and where these might show up. Sometimes those folks that are displaying individual acts of racism, I think, and this, forgive me if this offends you, but I think sometimes we have to forgive these folks. Sometimes we have to ask ourselves, is it our limited beliefs of who that person might be or what they can do that now forces me to put them in a box of perpetually being a racist? Or is it an opportunity to have a conversation where another person can then become an ally and evolve through their process of acting as a racist? I personally have caught myself, and one of my vulnerabilities is when it relates to gender roles. I've often been in a setting where someone might talk about a doctor or a nurse, and in my brain, I filed the doctor is a man and the nurse is a woman, only to my own utter embarrassment. But that is not who I am. That is not where I'm ending the process of my self-development. So that challenge might be in giving people those other chances and knowing the difference between systemic racism and individual racism. The other part in there is ego. Is this work really about me? Whether it be advancing the work, getting credit for the work, or being recognized within an organization as a change agent. And once I understand that the work is about the work, I can support it from so many different platforms. I think it's important that we celebrate small victories as we do this work because they're so few and far between, but we have to understand how we celebrate those. And then with addressing pushback, where I found a great deal of support is leaning in on the research and the data. Kirwan Institute is such an ally, and they've given us so many things that help to support what we're saying. So it's not me, the angry Black guy, who's sharing this information. It's The Ohio State University and their beloved Kirwan Institute that's sharing with us that there's 5 systems, if we look at them, are disproportionately affecting minorities, African Americans, and people of color. That school system, that criminal justice system, the housing system, health equity, and then workforce development. And how do we let these respected institutions almost speak to validate what we already know to be a pervasive and everywhere situation?
Thank you. David, can we hear from you on that 2-part question?
Yeah, one of the advantages of being the cleanup guy is that I can just say I agree with everything that was said before, because I do. I mean, this is all good stuff here. I think from my perspective, the only thing I would add is that, and again, speaking from the perspective of a white male, that if you are white, again, to lend your privilege, I think some of the barriers are, that folks in communities of color are not heard. Even when they're heard, they're not acknowledged, their stories aren't believed, their narrative isn't valued. So those narratives need to be heard, they need to be lifted up and respected. One of the things that I encountered in working in some communities when we would go in, again, in my work with the Kirwan Institute, was that we would talk about the disparate opportunities across neighborhoods, across cities, and we would encourage people to become politically involved. And a lot of times the pushback was, I don't know how to do that. Who do I talk to get anything done? I go to City Hall and I'm lost. I don't know. I don't even, sometimes it was as simple as I'm not sure where City Hall is, or I'm not sure where the department is that I need to go to speak to. So if you're someone who operates in those realms, if you're comfortable in operating in those arenas, political activism, whatever kind of activism it is, mentor, ask, can I assist you? But then mentor folks, help them discover where the levers of power are and how they manipulate them, I think is an important thing that an important contribution that you can make.
Thank you, David. Now I want to move on to the last questions, and you will get one question respective to you each. Dr. Plank, I'm going to go back to you. What is the purpose of the healing circles? You touched upon it earlier. We want you to expound upon it a little bit and describe some of the methods used and their intended outcomes.
So the racial healing circles are actually called RX Racial Healing Circles, were developed by Dr. Gail Christopher, who actually has a health background, so this is very related. And it's a methodology that she created that really takes a group of people. It's like up to 20 at a time. They were usually done in person, but we've now worked on a methodology for doing them through Zoom like this. So we've been doing them in an electronic way. And it's to get a group of people together, and there's a progressive series of questions that we do both with pairs and with the whole group to really work through the deep sharing, understanding, the getting to respond to some questions and to understand each other. And so it's helpful to talk about they're not some kind of diversity training that you often do. These are they're pretty intensive. They're 2 to 2.5 hours long of really engaging with others on some deep, meaningful questions to help really listen to others' experiences and get to really, truly start to see outside one's own bubble that we each walk around in. And so it's a methodology that works people again through these increasingly kind of challenging questions of thinking about things and sharing stories with partners and with the whole group to get a better understanding. They're meant to be healing in a lot of ways, and that's both for as a community, as people listen, but also just personally. And Dr. Christopher can talk about what it does for, the person going through it. We've been doing a bunch of them, and I'll put up a link later where you can email if you want to get involved, because we're inviting anyone. We have some scheduled for the next month or so. We can also arrange for individual ones. Like if you have a community where you want to do this in your community, we'd be happy to help you set up one and help facilitate it. We also do facilitator trainings to teach other people to do this methodology. But it is a way of bringing people together to having some really deep and meaningful conversation. Each one's a little different depending on who's in the room, but it's a way to truly listen to others, to understand their experience, and as a community to begin healing, as well as individuals to begin healing. And so I can also provide, that maybe can be distributed later, some links of Dr. Christopher talking about this methodology, but we've been doing a bunch of them, and they're really incredible experiences for, again, having people to truly listen and get to know what other people experience. I don't know if that answers for you.
Absolutely,
Okay, thank you.
and a robust answer too. And the links would actually be helpful to us so that
Okay.
we get that information out there.
I will put the email address people can write to if they're interested, and I can send them the schedule and they can sign up, or they can talk to me about setting up something in your community if you want us to do this. And I can also I'll put in a link that describes them a little more. So thank you.
Sounds good. Thank you. Going back to Mr. Moore, what are some of the disparities and inequities you have observed in your career in education? And the second part is, what impact have they had on families that you've observed and that you've learned through your experience?
Again, thank you for this opportunity to talk. And I don't think any of these disparities will come as a surprise to anyone on this call. But what we see is policies within school handbooks that penalize the natural growth of African American hair. We see policies and practices that punitively address students who are frequently tardy, and not look at a trauma-informed lens to understand how or why some of the things folks are experiencing in their communities might be leading to their tardiness, or whatever the situation might be. What we do wrong is we begin to apply values when we see certain behaviors instead of engaging that person in their lived experience, and putting on our listening ears to be able to truly and honestly ask what's happening, not what's wrong. And I think the impact on what we've seen in the past is very clear to us. The prison system is prepared to receive students, and many times the school system is only a preparation for getting those kids ready for the prison system. So what I feel very fortunate to have been a part of here is I've been part of a panel that has addressed policies in our handbook to look at it through a lens of racial equity and to begin changing these. And what I hope to become the norm is that it's an iterative process. Today, as we look at it, we might identify things that we'll see later on need to be updated yet again. It's very clear to us, and we heard it earlier, when that bomb of racism went off, it wasn't just our non-Black counterparts that ingested it. We've ingested it. So we have students who don't believe in their potential or their ability to live a life of their full potentiality because they've also breathed in the air that tells them they're less than or they can't compete on the level playing field with others. And so the impact is far and wide. I think, again, if we look at it interconnectedly, we have to address all 5 systems, or else we're playing a game of whack-a-mole. We can't just fix the education system without fixing the criminal justice system, without fixing the housing system, the healthcare system, and access to the healthcare system, and understanding how and why we might need people from these communities to have more access to trauma-informed care. And then lastly as well, that workforce development. How are we creating a workforce that's supporting with the outcomes being considered first? How are we supporting creating a workforce that reflects our whole community and engaging our whole community and identifying opportunities? So the work is big, but I think many hands make for light work. And so the more of us that join in this effort, and the more we have counties like Franklin County declaring racism a public health issue, the easier and the more idealistic this work becomes, or the more possible it becomes. So thank you.
Thank you. David, what are some ways that climate change inflicts harm on disadvantaged neighborhoods and communities of color? And what are some strategies to lessen the harm?
All right. Well, let me begin just by cutting to the chase. Let me give you the kind of the bottom line here. Okay. Things you can do to impact the planet right now: recycle, compost your kitchen waste, get a rain barrel, buy an electric car. I love the rain barrel thing, right? If you're scratching your head right now, wondering what in the world I'm talking about, those are recommendations, and they're very good recommendations if you have the means and the capability of using them. But I think the first thing you realize about environmentalism in this country is that all of those recommendations come out of an environmental movement that's been largely white and largely affluent. And the conversation around environmental justice, although it's been around for a long time, is something that we really need to grasp and take hold of and really take seriously. I want to read a quote. This is Dr. Robert Bullard. He's recognized as the father of environmental justice, University of Alabama, I believe. He wrote Dumping in Dixie, and it was all about communities of color in proximity to toxic waste sites, industrial locations, all the things that Dr. Barnett was referencing earlier when she was talking about zoning and redlining. He said that environmental justice is a concept of trying to address power imbalances, lack of political enfranchisement, and redirecting resources so that we can create some healthy, livable, and sustainable types of models. And that's language that is quite a bit different from some of the environmentalist language that you might hear when environmentalism is discussed. So Dr. Bullard's work focused on what I would call classical or more place-based types of environmental justice, the kinds of things that I just mentioned. So siting of toxic waste sites or industrial locations. It can extend to lead poisoning and lead paint in homes. And those are important, and they're really more kind of place-based. And I think for that reason, the strategies are more focal in nature. And so if any of the folks in the chats want to have conversations about any of those aspects of environmental justice, I think that would be a great thing to maybe follow up with some other conversations. I did want to focus on some climate impacts today, simply because those are more global in reach, global writ large, the entire Earth, but also global in that they tend to spread across communities, but not equally. And the two I want to focus on, climate impacts, are extreme weather events and specifically heat stress in our cities, and talking about the energy cost burden of households and ways to ameliorate those. We all know the climate is warming, and one of the impacts of that is that as the climate warms, our cities are getting warmer too. But they're not the same uniformly. If you go into some neighborhoods in Columbus, in Detroit, in Washington, D.C., in any city across the country, and you take the air temperature, if you go into low-income neighborhoods, if you go into communities of color and take the air temperature there, it's going to be on average about 3 to 4 degrees, and sometimes as much as 8 to 10 degrees hotter in those areas than in the more affluent communities. And one of the chief reasons for that is the lack of tree cover, the lack of greenery in those areas. And that's not an accident. It's a direct result of the policies and practices that Dr. Barnett was referencing earlier, zoning, redlining, those kinds of things that led to disinvestment in communities. Because think about it, if you're not allowing people to buy homes in a community, then nobody's going to invest in putting amenities in that community either. So you're not going to get stores, you're not going to get a lot of the services that you need, the tax-based declines, and you end up with communities where they're fairly decimated in terms of tree cover. One of the things you can do to address that is to plant trees. And in that respect, there have been some efforts to do that, but I would caution against what I call white do-gooderism, where that's concerned. There have been efforts to go into some neighborhoods to plant trees where folks weren't invited, and they've come up against resistance. I mentioned Detroit and Washington, D.C. earlier. In Detroit, there's a history of the trees being destroyed by the authorities after the riots and the social unrest in the 60s. The city's narrative was that they were clearing the trees because of Dutch elm disease. And the community narrative was that they were clearing the trees to clear sightlines for surveillance. So different narratives, but that narrative was part of the community narrative, the heritage there. And to go in then and propose, I'm going to plant trees here, there was some very freighted kinds of language around that and some resistance to that. The other thing I want to mention very quickly here is housing energy burden. And I want to speak specifically to energy costs, which make up about 20% of a household's total expenditures. If there's anything you can do to lower your energy costs in your home, so much the better, because that resource then is reclaimed and you can use that money for other things. A couple of the ways you can lower your energy costs Home weatherization is a thing you can do. Making your heating and cooling systems more efficient, sealing your home so that there aren't energy leaks. And there's a lot of assistance available to do those kinds of things. But lighting is about 20% of the energy costs of the home. One of the easiest things you can do if you have the means, and that's key, is to replace your incandescent bulbs with compact fluorescents and LED lights. Now, it turns out there's a huge investment, an upfront investment, because those fixtures are more expensive. But there are racial components to this as well, because from the University of Michigan, a study there has shown that these types of light bulbs not only are more expensive than the incandescents, but they're more expensive in low-income communities than they are in upper-income communities. So, you know, there are some things to address there as well. So those are just two examples. And actually, I want to tell you one real quick story here. When I gave this talk about a year ago about the compact fluorescents, about 2 days after that, I got an email from a gentleman who said, you know, I heard what you said. And so I put together this group on Amazon. I asked all my friends to buy LED light bulbs. So they're all buying these light bulbs, and I need a place to donate them. I had no idea. So, you know, it was kind of it was a real learning experience for me. And it was a great thing that he did as a result of this. It cost him very little to do this, but it was a very high impact thing that he was able to do to try to ameliorate that in his community. So let me stop there.
David, thanks for that. We are going to actually go back to a question that was prepared. We have one question in the chat box. So maybe we'll do the one question in the chat box because we've added a few more minutes. We only need a few minutes to wrap up to close out the program. This conversation and information is so robust. I do not want to stop the conversation yet. But the question in the chat is, how would you suggest a city start the process of declaring racism a public health crisis? And what would you suggest that they do to educate the community so there is widespread support?
I'm happy to share my insight on this if you would. I feel very fortunate to have spent time in Seattle, which in many ways is a best of class as it relates to corporations and globally influencing companies making a commitment to being anti-racist. And what I found to be very just like awe-inspiring when I was there is that I would meet the, let's say the CEO of the United Way, or the person that led the Youth Justice Center. Everybody would introduce themselves with their name, their title, but then they would tell you the year that they graduated from Undoing Institutional Racism. So there's this shared collective community ethos that those who serve people understand what it means to be a servant leader and the responsibility that comes with serving people, and the dynamic of systems thinking versus human thinking. And they're always publicly challenging where they are. And so again, I respect that space for being iterative and for creating opportunities to be challenged on limited beliefs. And I really look forward to a day when Columbus and Franklin County can be that far along in our process. But I do want to celebrate that we have begun that process in Franklin County. We've declared racism a public health issue. And today we're here talking about it publicly as it relates to community health. But we're also bringing in every sector because we understand where we're going with this. So that's my piece on that.
Thanks, Malik. Dr. Plank, would you like to weigh in on this one, or David?
Go ahead, Dr. Plank.
I'm trying to think. I agree with so much of what Mr. Moore just said, and so I would just reiterate that I think this happens at different levels, and so there are the kind of government action levels, but they're also, and where we're focused is on that interpersonal human connection level, and I think building those different layers into a community is one way to help with that. And so our effort is about bringing people together to really learn from each other and listen to each other, and I think that's also an important part of it.
It certainly is. David, can you
Yeah.
weigh on? Would you like to weigh in on that?
Yeah, I think I would add that, I mean, a declaration provides a touch point. I think we call it our North Star. And getting to that point is an important place to be. But I think as we have, made that declaration, we're also seeing that the implementation of it requires a lot of work. I mean, how do you know 6 months or 12 months, after a declaration that it's actually having the impact that you wanted it to have? And how do you help use that declaration to shape not only your own work, but other efforts in the community? So I think there's a huge education component that goes along with that. Dr. James, in I think his initial remarks, spoke to this when he said that, there are a lot of, organizations that are established in, addressing racism that think we're kind of outside our lane when we talk about, public health in terms of, or racism in terms of public health, when it's integral to public health. I think that's what I would say is that, it's in the implementation, I think, where, I'm seeing kind of the most work yet to be done. It's good work to do. I think it's important work to do. I'm really excited about doing it. It's level setting, and it's engagement, and it's education.
David, I can really appreciate those comments, all of the comments across the board. Obviously, I'm the moderator, but since this question came up, you're absolutely dead on. It's wonderful to announce our commitments and, commit to some actions. It's a great thing. I'm happy to know that our organization is moving forward with that list of action items. And many of us are key instruments in that toolbox, right? And you're right that one of the major challenges is the implementation and really managing that efficiently and effectively, and level setting also. So I appreciate all of those comments. We have a few more minutes. We were actually given an extra 4 minutes, and we have one prepared question left. If someone wants to tackle that, I will read. What tools or strategies do you recommend using to self-assess bias and racial attitudes? Who wants to take this one?
I mean,
no one.
if no one's going to go, I think, I believe it's Harvard's implicit association tests. They're kind of the gold standard, right?
Yeah.
That's where you can go through and see if your implicit bias shows up as it might relate to black and white, good and bad, or gender identity, and just continuing to do the work. And again, it's funny how as I've gotten older, I realize so much of the work in the world that I want to see that's different, it really does boil down to the change that's within me, and understanding where, although I'm a person of color and in many ways I'm the subject of racist systems, within the privilege I do have, am I abusing it or using it properly? And just being open enough and introspective enough to reflect on that and changing that first. And as I change that, I might recognize the work that's being done by friends, allies, partners, accomplices that are on their own pathway of changing who they are as well.
Thank you for offering that. David, did you want to take a shot at that?
Yeah, I'll echo what Mr. Moore just said about the implicit bias test. It's the Harvard IAT. If you Google that, you'll be able to find it. And being aware of your own implicit biases is very important. I know that there's, in the corporate world, there's a lot of talk and emphasis on having implicit bias training, and there's some question about whether it works in a group setting like that or not. But on a personal level, not just being aware of your biases, but then working further to understand them and embrace them. And the point I would make about that is that it's called implicit bias for a reason. Implicit means it's hidden. Doesn't mean it's hidden from everybody around you. It's just hidden from you. And if somebody, confronts you about a bias, you're not going to believe them. And let me just really quickly share one experience I had with a colleague who said that she was a female colleague, and she said to me one day that I didn't interact with her in the same way that I interacted with male colleagues. I tended to question her more than I did. I would just accept, things that male colleagues said. And I was floored. I was angry. And we got into a pretty heated conversation about it. It was probably an hour-long conversation. We both ended up in tears.
Mm-hmm.
I had to go away and think about it. What I concluded was that I'm married to somebody who's a top executive in a company, but she's also my wife, and I interact with her in both of those capacities. And I think what was happening with me was that I kind of tended to meld those two in my mind, and my implicit bias played right into that, and it came out in the way that I was interacting with my colleague. I tell that story because I didn't believe her. I was angry. I was incredulous. How could you accuse me of this? I'm married to somebody who's like really highly powerful and all of this stuff. Had to go away. It requires humility to be able to look at your own biases and embrace them and be confronted about them and continually do that work. Continually, and you don't have to, navel gaze every minute of the day to make sure that you're, on task against your implicit biases. But when they do show up, or when somebody points them out to you, accept that with humility. Give it the consideration that it needs, because that's a real opportunity for you to learn something really important about yourself.
David, I think that's a great last note to end this conversation on, to focus on humility. You're absolutely dead on. In fact, I'm seeing some appreciation for it in the chat box. We had one more question in the chat box, but we'll actually answer that in writing back to that attendee. And we're going to wrap up this panel conversation. I want to thank you all for such substantive, appropriate, appreciated remarks and answers, and your willingness to share and be open. We appreciate you. I'm going to turn it back over to Justine, and we're going to wrap up for the day. Thank you so much.
Thank you so much, Lisa, and thank you to our panelists. So our next slide here, this is like our call to action, but thank you for those wonderful discussions. I think we learned a lot today about the importance of acknowledging the inequities and impact of racism on our communities. Now, the final question for the day is, what is next? So in 2021, we'll be building a framework for the chats as they incorporate equity into their work. We hope to work with the chats and local municipal leaders to form COVID-19 defense teams to better coordinate resources. So before we close out this event today, we want to thank Region 5 Public Health Training Center for helping us make this event possible. We also want to thank Franklin County Public Health leadership for contributing to the success of this event and continued support as we work with the chats. And lastly, thank you to all of our guest speakers and panelists, Dr. James, Dr. Barnett, Dr. Plank, Lisa Dent, Kirsten Oliver, and David Norris for the valuable information you provided to us during these sessions. Thank you to all of you for joining us today to celebrate the work of the community health action teams and for learning how Franklin County Public Health is carrying out their commitment to address racism, and for joining us and hearing from leaders in various sectors on their work in combating racism. Please take a few minutes to complete the program evaluation. We really value your feedback. We want to hear from you. So enjoy the rest of your day, and please have a safe holiday season.
Hope to see you in 2021.
Yes.
When I wake up in the morning, love, and the sunlight hurts my eyes, and something without warning, love, bears heavy on my mind. Then I look at you, and the world's all right with me. Just one look at you, and I know it's gonna be a lovely day. When the day that lies ahead of me seems impossible to face, when someone else instead of me always seems to know the way, then I look at you